Thank you very much. Good afternoon. I'd like to welcome members to this afternoon's virtual meeting of the Rutland Health and Wellbeing Board, and to any members of the public who are listening in via Zoom. We do have a busy agenda, so firstly, to practical matters, I'd like to remind members of the board to raise their hand if they wish to speak, and to ensure that their microphone is switched on when addressing an item for the benefit of the recording, and muted when not. I'll refer to Jane from governance if I need to record a vote or for any procedural matters. Thank you. So moving first to the apologies, I have apologies from Penny Shop. Do you have other apologies, Jane?
Yes, Chair. I've received apologies from Dawn Godfrey, Louise Platt and Sarah Premer.
Thank you. Item 2 is Chair's statement. I will attach it to the minutes. There's just a couple of items that I will state now, although I don't think Adrian's with us. I would firstly like to acknowledge that Viv has, from Public Health, has now departed for a new role with Nottinghamshire. As a board, I'm sure the rest of the members will join in me in thanking her for all her hard work that she's done for the board. She will be missed. She's been replaced by Adrian, who I don't think is with us today, but we will meet him probably at the next board. Mike's going to come in just now.
Yeah, just by way of introduction, so I know a number of you will know Adrian Allen is an existing member of my departmental management team, has always had responsibility for kind of design of services and delivery within public health. So he's taken on board the sort of lead public health consultant role with Rutland as an addition to his existing portfolio, as opposed to being new into the organisation. So particularly given his knowledge of the Rutland service offer that we do, I think it will really help. And I know he's made strides to get to know a number of people across the organisation already. So a new to the portfolio but not a new face is probably the best way of describing it. And he would have been here, except he's covering for me in another meeting, which means I can be here and not him. So, but I know when he can, he will be.
Thank you very much, Mike. I'd also like to welcome Catherine Wilson, who is the Health and Wellbeing Integration Lead for RCC. She has replaced Sandra on and will be helping us on the board. So we'd also like to welcome her. I will attach my statement to the minutes. There wasn't any point in me doing a long-winded one. We are going to cover most of the points that I would say in the meeting on the agenda. So I'll move swiftly on. Item 3 is the record of meeting, and it's to confirm the minutes of the Health and Wellbeing Board on the 12th of July. I'll propose them. Do I have a seconder? Thank you, or any comments? No, I think John and Deb, is your hand up for a seconder? Excellent. So all those in favour of accepting the minutes? Thank you very much. That's taken, Jane. We had 4 actions arising. The first was me, and hopefully I did notify members of the date for the first meeting of the Health and Wellbeing Partnership. We have had a meeting today as well this morning, so some of us have driven quite quickly back from Leicester to our various places so we can take part this afternoon. The second were amendments to the update reports would be discussed at the next meeting of the IDG, and the agree way forward reported back to the chair and to the strategic director of children's and families. In Sandra's absence, Deb, that comes over to you. So I don't know if you wanted to update on that.
Thank you, Chair. I'm Deborah Mitchell. I'm the Deputy Chief Operating Officer for the ICB and Place Lead for Rutland. So we did have some delay with the changes in the report because of change of key personnel, with Sandra leaving and Viv. So we discussed the new format in the IDG. What we haven't done yet is formally asked you as Chair, Councillor Harvey, whether or not you approve it. So when we cover the item in the agenda, we will be asking for formal approval and feedback today.
Okay, thank you. Item 3 were all members of the board were requested to complete the consultation on the proposed pharmaceutical needs assessment. I'm hoping everyone did. We do have that. That has been approved, I think, and we've got it further on in the agenda. So I'll move on to 4, which was the report on the primary care access, diagnostics and outpatients. That is also on the agenda. So we'll move on to declarations of interest. Is there any interest to be declared this afternoon? No, I can't see anyone jumping. Thank you. Petitions, deputations, questions. Jane, have we received any?
None received, Chair.
Thank you very much, Jane. Questions with notice from members?
None received, Chair.
Thank you. Notices of motion from members?
None received, Chair.
Thank you. And so we'll first move on to the joint strategic needs assessment update and timeline. We've got 2 parts to agenda item 9. The first is the report from Mike Sandys regarding health inequalities in Rutland. So we'll move to Mike.
Thank you, Chair. Now I'm hoping against hope at this point that Mitch will come in because he's got the presentation and the detail. Yes, thank God for that. So Mitch, straight over to you, I think.
Brilliant, thanks, Mike. Jane, sorry, have you got these slides to share, or do you want me to do it from my end? I can do it my end if that's easier.
Can you do it from your end, please?
Yeah,
Thank
of
you.
course. Right, could someone just confirm you can see them okay? Brilliant, thanks, Mike. Okay, hi everyone, I'm Mitch Harper. I'm the strategic lead for Rutland in Mike's public health team. So I just want to introduce some key highlights really from a recent report that we've completed for Rutland's Health Inequalities Needs Assessment. So this is within the Health and Wellbeing Strategy Delivery Plan. So it's a requirement within that. The report is attached as an appendix with some supporting recommendations from the report as well. So hopefully you've had a chance to look through in detail. It is quite a detailed report covering a broad scope, but I'm just going to take you through a few highlights and then touch on the recommendations for the board from there. So firstly, just in terms of the scope, on the left-hand side here, you can see there's 4 overlapping dimensions of health inequalities. This is kind of national evidence base for health inequalities and guided the kind of approach that we took. So covering socioeconomic groups and deprivation, the protected characteristics in the equality duty, geography, comparisons between urban and rural areas, and inclusion, health and vulnerable groups. So it's really because of Rutland's small population size and rurality, we really wanted to delve into small geographical areas across Rutland, just to really pinpoint any hidden need that we may be experiencing across different areas of Rutland. So firstly, just in terms of a broad kind of scope in terms of life expectancy, and this is just to kind of emphasize the point which kind of resonates throughout the whole report. Life expectancy from birth in Rutland is higher for both males and females compared to the England comparator, as you can see from this top section of the slide. That is a common case across a lot of health outcomes for Rutland. However, it's important to note this second part here, which shows, although overall it is higher for Rutland life expectancy, there is variation between the most deprived areas of Rutland and the least deprived. So you can see for males, that's about 3.9 years between the most deprived and 4.9 for females as well. So it's just to emphasize that point. And like I say, that resonates as we kind of delve into the detail as well. So the first section is quite a busy slide, and apologies if you can't quite see some of the text, which is quite small. But this is just the first section on the socioeconomic and deprivation factors. So this chart on the left shows the proportion of children under 16 in relative low-income families. And this resonates again with what we saw on the last slide. It's broken down by small geographical areas of Rutland, and all the small geographical areas are better than regional and national comparators. However, there is variation within Rutland. So for example, we can see Cottesmore at around 15% of the population, children in the 16 population within relative low income families. And that compares to around 3% for areas such as Ketton. Then on the right-hand side, kind of expected for Rutland, but good to see it visualized in a map form as well. This outlines the barriers to housing and services domain of the indices of deprivation. So that covers the physical and financial accessibility of housing and local services. The deep purple areas here are within the 10% most deprived within the country. So as we can see, a lot of those kind of most rural areas of Rutland are within that highest 10% most deprived, related just to barriers to housing and services. Just from the economic sense as well, when we look at service demand, an example related to the Rutland Food Bank shows how things have changed over the last few years. So for example, the number of meals provided by Rutland Food Bank was around 5,500 in 2015-2016. That's increased to around 42,500 up to 2020-21. And given the current cost of living pressures, in addition to the COVID-19 pandemic, we'd expect this may continue to increase. Section 2 of the main report covers rurality and access. I'm not going to go into this one in too much detail because there's lots of mapping within the main report. But what we've looked at is kind of modelling across the all-party parliamentary group on rural health and social care report, which looked at the 5 common characteristics of rural health. So we wanted to explore whether these were applicable to Rutland, which if you look at these 5 that are here, they probably do resonate with us, and we've of course heard these resonate with our residents as well through consultations. And then just one example from this section on the right hand side is related to the Digital Exclusion Risk Index. So this looks at the digital side of things based on deprivation, demography and digital connectivity across the county. And you can see the variation here as well, with the red areas kind of most at risk of digital exclusion. The third section of the report covers the inclusion health groups, vulnerabilities and large population groups. We wanted to include the armed forces community within this. They're not necessarily an inclusion health group. However, given the large proportion of armed forces personnel and veterans within Rutland, we wanted to explore whether there is inequality within. National and local insight suggests that there may be signs of inequality within the armed forces community, and in particular that relates to female veterans around mental health and social relationships. And then 3 of the more kind of traditional inclusion health groups, which often as a population experience poorer health outcomes than the general population, we have carers, homelessness and gypsy, Roma and traveller communities explored. Some of this is dependent on Census 2021 data being released to kind of firm up the evidence a little bit more locally, but all of these populations generally experience poorer health outcomes. Related to carers, we've seen the number of carers, unpaid carers especially, increase considerably during the pandemic. This is potentially decreased based on the evidence, but we need to understand that through the census. Homelessness rates are better than national averages. However, in 2020-21, there was still 85 Rutland households who were owed a homelessness prevention or relief duty. And predominantly the reasoning behind this was related to breakdowns in relationships and domestic abuse, which was self-reported by these households. Gypsy, Roma and traveller communities, there's lots of evidence around inequality within this population, and we're not in a position to understand locally yet, but Rutland County Council have commissioned a accommodation assessment which has started in September. The last section covers protected characteristics. The main report does cover all protected characteristics. However, I've just picked out a couple of highlights just for the purpose of highlighting the key findings. On the left, this covers disability or long-term health conditions. So it covers all types of disability. And this is just to demonstrate levels of physical inactivity and just showing that Rutland does have a higher level of physical inactivity across disabilities compared to England and regional comparators. So potentially a priority area for us to consider. On the right, we cover age as well, and Rutland has a significantly high proportion of people aged 65 and over than England, and 80 and over too. This is from the latest Census 2021 data, and we've seen previously in slides, but just to re-emphasize the point in terms of protected population increases up to 2040, as we can see from this chart in the bottom right hand side, as the age groups go up, the projected increase in population does increase with that. So something that we need to think about in developments of things such as the local plan and other areas as we're planning health services and wider health and wellbeing, council services, etc. I'm going to end there just because I'm conscious of time. But the two key kind of recommendations for the board from this are to note the report findings, in particular across the main report that's Appendix A, and approve the publication of the needs assessment on the Joint Strategic Needs Assessment website. And then the second aspect, because this is a very brushed through kind of highlight version of what's there, we were thinking about the opportunity for a health and wellbeing board development session where we can bring in wider partners as well to really delve into the needs assessment findings and have a further discussion on some of the report recommendations set out in Appendix C, but also any that are missing that members and wider partners may want to contribute towards that. So I'll pause there, Chair, and if there's any thoughts, I'm happy to take any questions.
Thanks very much, Mitch. Councillor Wilby was first, then Dr. Underwood.
Yeah, sorry, just a quickie. You, in your data deluge there, you said that there was a rising problem with female veterans and their health issues or their mental awareness. Can you elucidate a bit on that?
Yeah, sure. So to be honest, it's kind of a point, because we've not looked at health inequalities at this level before, it's not necessarily an increase in problem, it's just a snapshot of what we've got available at this present time, both within the national evidence base, but also local insight that's been completed by partners. And it's very much related to self-reported. So that aspect is more based on national evidence base. So it's potentially something we want to explore more locally to understand whether that's the case. And it's very much relating to that transition period from being a serving personnel into veteran kind of civilian life and adjusting into that different lifestyle, really. So it's just a snapshot. It's not necessarily saying that's increasing over time. It's just that's where we are now. That's what some of the evidence says nationally, and maybe we want to explore that more locally.
Okay, thank you.
Thank you. Dr. Underwood. You're on mute, I'm afraid.
Am I to assume that you're not going to go through the actual text of the Joint Strategic Needs Assessment, which is in the next, sort of follows on from your presentation? And if so, can I raise a couple of corrections that's in that document and also a query, please? So my first comment is on page 50. I think you've put about those different surgeries that Rutland people access. I live on the Melton side of Rutland, and quite a few people in the village I live in actually go to Melton Mowbray for their GP practice, and you haven't included that in the document. And then on page 60, you've got a typo, and you've put getting of the farm rather than getting off. So minor details for those. But my question more is, I was at an ICB meeting a few weeks ago, but it seems like ages ago, when I realised that Rutland isn't getting any funding under the Core 20+ strategy. It's that all the funding is going to Leicester and Leicestershire. And I queried this, and apparently we don't qualify for it. But what I'm wondering, now you've actually got this sort of extra detail of deprivation, is there any way in which Rutland can sort of have a share of that funding, or are we still to be excluded? Thank you.
Are you happy for me to come back there, Chair?
Of course.
So thanks for raising those points. Firstly, the kind of errors within the document, I'm happy to explore those. We did set for the primary care GP surgeries a certain boundary, which I think was 3 kilometres over the boundary. So maybe that didn't pick up Melton there, but we're happy to kind of explore widening that further if there is anecdotal basis to say that a lot of people living in Rutland are accessing those. And the grammatical error, I'll correct that as well. That's absolutely fine. Just in terms of the broader question around the Core 20+5, I'm, to be honest, probably not best placed to answer that because I've not kind of been involved in setting the criteria. So I don't know if any ICB colleagues want to come in, or possibly Mike.
Yeah,
think
shall
Mike's
I
gonna
come in
come
on
in.
that one? Yeah,
Thanks.
so that one goes back to we do get, there's two bits to this. There is the core 20, which is the 20% of the population that's most deprived across the country, and then there's the +5. What Rutland hasn't got is any of the 20, the core 20 money, which, unless Mitch tells me otherwise, is still the case that although Rutland has got relative deprivation, has got pockets of deprivation, it doesn't actually have any areas which would feature in the top 20% most deprived areas across the country. Hence why that LLR funding is really weighted towards the city, because they do, and to a lesser extent towards Leicestershire as well. What Rutland does get is a small element of the +5 bit of funding, which is more slanted towards the those 5 kind of conditions and the rest of it. So I mean, it's the only check, Mitch, is given what you've put in the health inequalities test, it's still the case that we don't have anything that features in that top 20%. So that'd be why there's no change there. Janet is the answer, I think.
Thanks, Mike.
I tried.
John, would you like to come in?
Yes, please, Chair. Just to thank you, Mitch, and the team. I know there's a great deal of work and a lot of time that's gone into this document. Specifically for me, on your second question to the board to approve development of a Health and Wellbeing Board development session, that is something that I would very much welcome personally. Specifically, as we hope to be going into further integration with our services going forward. And it's very important, I think, that we as a system understand these things together and therefore can best focus our respective services onto those specifics that we as a system identify. Just to say that, so I very much welcome that.
Thanks very much, John. Mike and then Deb.
Yeah, so John's beat me too, because I was going to do the thanks, Mitch, as well. But yeah, genuinely, thank you, Mitch. I don't think we've ever had, from a Rutland perspective, the amount of detail on health inequalities that we've got within this report. Like John, I would welcome the development session too. I was going to suggest we probably need to think how best to phrase the kind of the lenses, if you like, at which we look at health inequalities in that session. Some of this for me is looking at the overall outcomes around health inequalities at the different groups that you've exposed across a variety of different groups, and how do we do something about improving the outcomes. And then there's that split in terms of what can we as members of the Health and Wellbeing Board do that is about sort of wider determinants and housing and some of the follow-ons that you said. Some of that should really be more specifically for me about what can we do to improve access to services for those groups that have not got as good access as others by virtue of the inequalities they face. And then the other bit, I suppose, is just more generally, I mean, there is a temptation to look at health inequalities and go, well, why should we? It becomes a moral argument, but there is a bit of me, I think, for the board, I do think this is about efficiency as well, and nothing knackers your ability to have a productive economy than health inequalities and having parts of the population which basically are not as healthy as others. So whichever side of a political spectrum you might be on, I would say this is not about one administration or the other. It's really important that we have a productive population where health inequalities are reduced, and that's about making Rutland as productive as it can be. So thank you, Chair.
Thanks, Mike. Deb.
Thank you, Chair. Mike's stolen most of my thunder, but just a couple of points. So thanks, Mitch, for the report. I mean, it is really detailed. We're going to get another opportunity at our IDG on Thursday to look at some of these issues. And going back to Dr. Underwood's point, it is difficult when you're trying to balance out resources across the whole of Leicester, Leicestershire and Rutland, because overall, as Mitch highlighted, Rutland sits in a better position. I think it's the onus is on us, and probably part of the development session and part of the link and work that we will do with the IDG is to see what we can do with our own resources to try and target some of those inequalities, particularly when they link to poverty and some of the rurality issues. So we need to draw those three factors together and look at how we deploy our own resources, as well as obviously reassessing some of these outcomes against our 5-year strategy. We're in the beginning of that 5-year strategy, and now we've got some rich information to actually test some of the things that we've got in there, and it will inevitably be an iterative process. So I think this is probably one of the best pieces of information that we've received at the board to be able to inform our work going forward.
Thanks very much, Mitch. Deb, sorry, Mitch, do you want to come in?
Yeah, thank you, Chair. So just to thank everyone for the comments already. And I guess from that resource perspective, it is very much looking at how our universal services in particular could potentially target some of that where capacity allows on those most in need. And just making sure we're doing that collectively across kind of our partnerships to really have some impact, because of the smaller areas that we're looking at within this, we can have some real kind of impactful work in those areas of most needs. And just my final kind of comment on thanks to everyone else as well, because there's been a lot of partners within this. It's not just been kind of a piece that I or public health have looked at, and that's really added to the insight available to us to have a real collective view of kind of the picture really. So thanks to everyone that's inputted so far.
Thanks, Mitch. Just one comment from me, and it talks about the development session. One thing that I think would be really useful, I'm very conscious, and it is right, if we look back to last couple of pages of our pack down at 347, 348, we're aware that some further census information that details specific demographics and that will really speak to this is due out. It is late, it's due out at the end of the month. I might make the suggestion that as a board we possibly wait till we have that further enriching data before we maybe have the development session, obviously keeping an eye on timelines, noting that it's already delayed. I wouldn't like to wait. If it's going to be delayed another 6 months, then that wouldn't seem best. But if it is coming out in the next month or so, then it is perhaps worth us thinking as a board of waiting for the development session until we have that further information that would just help us to develop that further. I don't know whether everyone else is in agreement in that. So we are looking to note the report findings and approve publication of the needs assessment on the JSNA website, and also approve the development for a development session on health inequalities with a deep dive on the needs assessment and a further discussion on the report recommendations set out in Appendix C. I'm happy to propose that. Do I have a seconder? And then is everyone in favour? I think so. So we'll move that. And Mitch, I think it will be you. Are you happy to kind of keep an eye out when that further detail is coming available? And perhaps if you get more of an idea on date, you can let us know so that we can then look at doing that development session, if that's okay.
Yeah, sure, that's absolutely fine.
Thank you. So Jen, can we make that an action, please, that we do that and then develop the session? Thank you very much. Now the second part is from Mike, I think, on the end of life needs assessment. So Mike, over to you again.
Yeah, so same for me, just brief words of introduction. So this one, the primary author and puller together of the JSNA chapter on end of life is Sean McGill. So Sean was training with us, has now gone on to other things, but is back by special request today to present the findings of the end of life chapter. So Sean, again, I could just hand over to you, and if you can take us through the summary of the chapter.
Absolutely, and thank you very much for having me this afternoon. I'm afraid I'm not used to Teams, so I'm just going to try and share my screen for you. There we go. And can everybody see that? Is that presenting
yes,
okay? Yeah, great. As I say, thank you very much for having me today. So we've undertaken a joint strategic needs assessment chapter on end of life. It seeks to provide an overview of the data and on the care and support for those who are themselves at the end of life, their loved ones, those who work in the area, and also informal carers. This was done by collecting data, sorry, computer's freezing. This was done by collecting data from multiple sources, including from local organisations and services, locally commissioned reports, nationally collected data, and a literature search. We also undertook an online survey to better understand and incorporate the lived experiences of local people, which I shall be discussing shortly. So the document follows the standard JSNA format, starting with a consideration of which populations are at highest risk of negative care and support related outcomes. And then we follows on by looking at the level of need in Rutland. Across England, nearly 42% of people die in hospitals, despite it being identified as the preferred place of death for only about 3% of the population. In Rutland, this figure stands at around a third, which is significantly lower than the English value. A further third of people in Rutland then die at home, which is the highest proportion of any local authority in England. And then around 28% of people die in a care home. It's important to note, though, that for some, this will be their usual place of residence, and so that distinction between home and care home is slightly blurred. Then finally, only 3% of deaths occur in a hospice, which is similar to the proportion seen across England. So the survey we undertook sought to collect the views of bereaved individuals on the care that their loved ones had experienced as they approached the end of life, the experience of bereavement support that they themselves had received, the experience of informal carers, and also of staff. So it was quite broad ranging. A total of 51 people responded, 13 of whom had been recently bereaved, 7 had experience of being an informal carer, and 36 were paid staff working in end-of-life care. Some of the most striking results are highlighted on this slide. A common theme that arose was that people would generally seem to be quite unaware of the services available to them and found it difficult to access those services with lots of different routes into each different service. Informal carers also highlighted a lack of training, with 57 of those who responded stating that they did not feel they'd received sufficient practical support to care for someone near the end of life. Furthermore, informal carers also told us how the burden of trying to navigate that complex system often falls on them, and this makes an already difficult position that much more so. One emotive response that we received was highlighted at the top here. I had to cope alone. It would be far better if additional support at home was offered up front. You have enough on your plate without having to try and find what help is available or keep pestering when no help is forthcoming. I was supporting my partner alone and taking him to all his medical appointments, which just sort of really sort of epitomized a lot of the messages that we were getting back through that survey. So collating our findings from those multiple sources, including the survey, we identified a local of unmet local needs for this population, summarized here, and they included the need to support people in having conversations about end-of-life preferences so that they're more likely to be realized. That there is a lack of coordination between services, with it being unclear to residents what is available and how to access. That there are limited community out-of-hours services supporting people to remain at home. And informal carers and staff do not always feel that they receive sufficient training and support. So in order to try and address these gaps, we've produced a number of recommendations from the report. First, we recognise the need to explore some of the highlighted areas in further detail. This includes by undertaking a tailored piece of engagement to capture the voices of those who are themselves approaching the end of life, undertaking a health equity audit to see how those from disadvantaged groups are affected differently, and to explore how accurately advanced care plans are being followed, especially when people interact with systems outside of LLR and different systems are in use. To support people talking about the end of life, we recommend seeking to promote conversations at times surrounding major life events via a Making Every Contact Plus Count Plus approach, and exploring how behaviour change theory and social marketing could be used to help improve the acceptability of having these conversations. We also recommend encouraging healthcare staff to initiate advanced care plan discussions during early interactions with patients that can contribute more meaningfully. Whilst we have a lot of local services, as I've touched on, a lot of people are often unaware of those services. We therefore recommend local campaigns and resources to help increase the public's awareness of these and understanding of end of life. Dying Matters Rutland already has some excellent work in drawing these resources together, so we recommend building further on this. We then recommend developing a more robust community out-of-hours offer to support people staying at home at their preferred place of death, and to work to improve the coordination of services that work together to deliver end-of-life care. There's also an absence of dedicated end-of-life care beds in Rutland, and we recommend looking at ways to introduce this service so that travel burdens can be eased for local residents. Also, a recommendation considering the need for a dedicated paediatric palliative care consultant has just been added to the report since submission of this paper. So I'm afraid it's not included in the slide deck, and I apologise for that, but it will be in the final JSNA chapter. And then our final set of recommendations relate to supporting carers and staff specifically. This includes through providing additional support for informal carers to take respite care, providing additional training and support, and considering how regular check-ins with informal carers could take place. So the JSNA chapter will be uploaded onto the Rutland Council website shortly alongside the JSNA chapters. I just am updating the references this afternoon. Building on this work, the Integrated Care Board are in the process of developing the LLR end-of-life strategy. The JSNA chapters for Rutland, Leicestershire and Leicester are going to be feeding into this, and I've been informed that all three are quite well aligned and have a lot of common messages and findings in them. That is it from me, so thank you very much, and I'd be happy to take any questions.
Thank you very much indeed, Sean. Do we have any questions? Mike.
Yeah, thanks, Chair. So I'll go first. Thanks, Sean. If I did a compare and contrast with the health inequalities one, they're both great. There's a slightly different feel about this one. The health inequalities one, as Councillor Wilby was saying, was very much a data deluge. We've not had a level of kind of broad data before now. We need to go away and think about it as a board, and where do we take it? This one, I like this. I like that it has got some specific recommendations in there that relate to Rutland and the gaps that you expressed in that slide around the gaps in provision across Rutland. The other reflection for me, before I come on to what was the question, some of that looks to me like low cost, so, or at least relatively low cost. So the provision of advice, telling people what services are available, sounds like an easy win. Ditto a kind of engagement session with people to talk to them a bit more fully about their experience. Yeah, okay, that won't cost the earth. Some of that maybe is kind of medium term cost, you know, so service developments. And then at the end, your comment about the lack of end-of-life care beds within Rutland, that feels to me like a big infrastructure cost implication. None of which should put us off. And I guess my question was going to be, whose job is it to take this forward? Now I can see you've got the second recommendation about this feeds into the LLR-wide end-of-life strategy, and it's the job of the ICB to do it. The sort of question and query, I suppose, in my mind is, we need to, and who's the we in this, make certain that the Rutland elements of what you've just discussed goes, you know, is really shot through that ICB-wide strategy. So again, I'm looking around the screen, just thinking, whose job is it to make certain that we raise that? I'm sort of happy to on behalf of others. And then the other bit is just in terms of thinking what's the level of resource that they will need and we need to support to make some of this happen. And one last point, I was really struck by that first slide in terms of, for want of a better phrase, where people die in Rutland. So the bit about end-of-life care beds, I'm assuming that drives why, on the one hand, we've got something good in Rutland, which is less people die in hospital because, you know, ideally they'd be dying at home. And yes, we've got more people dying at home, but we've got markedly more people dying in care homes compared with national average, and markedly less people dying in a hospice because of the lack of hospice provision within Rutland. I'm kind of assuming that's a sign, therefore, that there's people probably dying in care homes that are receiving suboptimal end-of-life care, because they're the kind, you know, that some of those people would be better off in a specific end-of-life care bed, whether provided within a hospice setting or elsewhere. So it's a bit of a jumbled ramble, but in essence, whose job card is it? Can we split these up into a kind of sense of what costs money and what doesn't, to then feed into that? And am I right in thinking that, you know, the big one for me, the real big long-term one, is actually about the provision of end-of-life care beds?
Thanks, Mike. Just before I bring Deb in, I'll just jump on because my comments were very similar to Mike, so it makes sense for me just to add this bit. This seems to, some of these recommendations, I was going to ask whether as a board we feel we could join them up with the dying well section in the plan, and that seems like a good fit, that if we can fit some of them in around that, we can measure that we are actually taking up some of those recommendations. I'm going to drop James in it slightly, but I'll probably come back to Deb. I just had a look on our plan, and it's James and with Charlie, who are the leads on section 6, which is the dying well. I'll bring Deb in because she might be able to answer that, but apologies, the Labradors are saying hello to someone. But I will, I didn't know what others felt around that, so I'll bring Deb in.
So again, you're still on a bit of my thunder, because I do think we need to look at some of these recommendations as part of that dying well element. Charlie, who's listening in the background, has just sort of sent me a note to say that they're looking at commissioning some beds directly from Thorpe Hall, which is a hospice in Stamford. So and that's via the personalised budget element. I mean, some of these recommendations, as Mike says, are quite relatively easy for us to pick up and implement. Some of them will take longer. This is a really important piece of work, so we will take this through the IDG. Obviously, myself as place lead for Rutland on the ICB, and James as clinical lead for Rutland on the ICB will make sure that we represent the Rutland element of this as part of the ICB discussions, but recognising overall, and I haven't seen the output from Leicestershire and Leicester City. I suspect we might be worse off in an area like this for Rutland because of some of the rurality issues, and the fact that we don't have as many care homes and opportunities for end-of-life beds that there are in some of the other areas. So we will pick it up in that way. I'll pick it up through as part of the plan, take through an IDG, but we'll also link in through the ICB. But some of those actions are not just health actions; they're overall, which would be picked up by our overall health and wellbeing strategy. Sam, I don't know, did I answer your question?
I think you did. Yes, you did. David, would you like to come in?
Just a quickie, I've got no trouble with the paper whatsoever. I thought it was nice, concise and to the point. But it's something which has always occurred to me every time I've seen the phrase dying well. And it seems to be an anomaly of speech, really. I just wonder, is it just me, or should we have something like dying gracefully? Dying well always grates on me. It's only a minor comment, but I think, well, maybe it's just because I'm aircrew. Yeah.
I know we can. I don't know if anyone else shares that thought. We could maybe have that conversation off. Maybe we can pick it up with James, who has that section, and we can decide whether we want to rename it. Oh, James is going to come in. And he's on mute, I'm afraid.
Thank you. I tend to agree. I think it's grasping the nettle in the name, and sometimes I think guiding people to the website, which I think is tremendous. I think there could be a question about how we can make it a slightly more attractive name to look at. And it's difficult because I think when you are asking somebody to go on a website that says dying well, I appreciate this, the dying well matters. What you actually want to do is have people on there well before they actually are in desperate need of their services, so they can inform themselves almost like a year beforehand. And I think there is a question about, is it an intimidating name of a website? And it'd be quite interesting to look at what options we could put forward for that.
Yeah, I think that's happy. If we want to have that discussion offline, that would be great. Catherine, and then Deb is coming in, and then Mike. There's a slew of hands gone up quickly on that. Catherine, you first.
Thank you. I just thought it was worth mentioning, because a lot of that was around informal carers. And we have recently done some communication engagement with carers. We've got an engagement and co-production lead, as you know, and recently been working on the carer strategy. So I'm just wanted to highlight that perhaps we could, when you're talking about engagement, link up with our carers team and our communications and co-production lead as well, if that could help going forwards.
It might well do. Thank you. Deb.
Thanks. I was just going to respond on the dying well, and I can understand, Councillor Wilby, your views about the term. It is a national term, and it becomes part of a national strategy. It doesn't mean that we can't rename it, I think, but we would need to be able to link it because of a lot of the communication and policy that's set nationally on it. So, we can certainly consider a different name locally, but it would link to that national policy.
Thank you, Mike.
Yeah, that sort of get where Deborah's coming from. I was going to ask though, Sean, I suppose it's whether calling it something in particular leads you down a particular path, by which I mean by calling it dying well and end of life care, do we see sort of death as the end point, and therefore the way we've gone about the needs assessment is thinking about the support we need to provide to people to get them to the end point of death? I mean, the terminology never makes sense. Whereas if you might look at it through a different lens and look at death and bereavement and grief and start bringing a number of other things which we would want to get people to think about, things that undertakers do, knowing what goes on around the back of a crematorium, where crematoria do open days around what happens in undertakers, in a way that then is reducing a kind of, not the stigma, but that kind of, we're all going to die of something at some stage, and you may as well get used to that idea. And then you start putting in place a plan that's almost kind of death and beyond, which gets into bereavement, grief for the relatives, and everything else. So it can be a very, very long conversation, but I suppose I'd just be interested in your reflections on what kind of lens you were looking through for the needs assessment, and whether that was shaped by the terminology we just chuck in.
Yeah, thank you. We were keen to approach this not just seeing dying as the end point, but recognizing that it has large, wide-ranging impacts beyond that, especially for the loved ones who are left behind, even for informal carers when they're then trying to get over that loss and then integrate back into society and get their lives back, in a sense, because so much time has been spent with that loved one. So I think it's much wider than that, and I think that dying is almost like a transition point for those people, but it's not an end there. And so I agree that some of the terminology is difficult, because it seems like once you reach death, that's the end of life care, when actually it carries on much more than that. If I've made myself clear there.
Thanks very much, Sean. So there's no more comments. We were going to endorse the recommendations arising from the end of life chapter, which does seek to meet the needs and gaps identified therein. And we were going to note that it will be used to inform the refresh of the LLR end of life strategy, which will be undertaken by the ICB. I'd also, with the board's agreement, I think we should add another recommendation to that, if you don't mind, Jane, that says that we will take forward the recommendations and integrate them into our end of life chapter, of our local our local strategy and the plan, and we'll see whether we have some crossovers. Appreciate the longer term thing around beds would maybe need to look much longer term and would be a bigger piece of work. But I think if the board are in agreement, and also Councillor Wilby's question around the name, so I think if we add that on as a recommendation as well, that we see whether with co-production, whether we can think of a slightly better name that describes more fully what this chapter is about, I think, because I take your point, David, and yours, Sean, that actually it is a part of a journey, and actually there's a whole lot more encompassing it. So if I propose those and make those changes, do we have a seconder who's happy to agree? I think Janet put her hand up, thank you. Are we all in agreement with that? Yeah, I don't have anyone shaking their head or so that's great. Did you get those? Sorry, Jane, I've kind of messed all those recommendations up, but have you got them? Thank you very much indeed. Now we'll move on to our next bit. I'm very conscious of time because my time management has gone out the window already on the first things. Doesn't bode well, does it? But we're going to be quick on this next one. So we're on to an integrated care system update. I think it was going to be a report from Sarah Prima, but she's unable to attend. So we've got this bit from you, Deb. So I'll come over to you, please.
I will be very quick. It's a very short update paper. And in fact, Chair, given that you've been at the partnership meeting this morning, I'm sure you'll have a further update. So just to confirm that the ICS is comprised of Health and Care Partnership, which is a combination of the 3 upper tier local authorities, the ICB and Health Watch, and also the ICB itself, which is a statutory organisation. In terms of the partnership, they've had a couple of meetings now, and there was a further one today, but initially they identified 3 priorities, and I don't know if there's been any further update from the meeting today, but those 3 priorities were cost of living crisis, access to services, and harnessing resources to support our populations. In terms of next steps, there's a requirement to produce an integrated care strategy by December 22, which is the initial deadline. Obviously, there are 3 health and wellbeing strategies for the 3 upper-tier authorities, and they form a really good start as part of that work. But submitting one for the integrated care partnership has to be completed. There's quite a lot of similarity, I think, in those health and wellbeing strategies, but obviously with different emphasis based on population management. In terms of the ICB, the governance has been signed off. The first couple of meetings have concentrated on plans for emergency and urgent care through the winter, primary care access, selective care recovery, and finance, performance and quality reports. Next steps for the ICB are a 5-year strategy, which will be informed by the integrated care partnership strategy. And the submission date for that is March 23. There will be a particular focus, obviously, on winter and patients being safe for winter over the next few months. The ICB did hold a public Q&A in September, which was attended by 40 members of the public. That went quite well. I think there was a lot of quite very sort of straightforward questions and requesting information back from ICB members, and there's a plan to rerun those 4 times a year. So we would encourage people to attend those if they had any questions specifically for the ICB. I'll draw a line there, given that we're short on time, and I don't know if you've got a further update on the partnership meeting today, Chair.
Yeah, I'll do a quick update. As you said, we were at a partnership meeting this morning. We did discuss the cost of living crisis, and it was a development session on the cost of living crisis. The ICP is due to meet again on the 27th of October, and there will be a paper come forward from today, so we'll be able to update fuller probably in the minutes. I don't know whether Mike or John, if you took that from the meeting as well, that we'll probably be able to attach something to the minutes that gives slightly more detail on what was discussed today and what as a partnership will be taking forward. So the partnership discussed what we could do, what we would be doing at a system level, as opposed to a place level where we have that later on in our agenda. Just regarding, Mike will come in a second, but just regarding the joint strategy, so this would be the partnership strategy. I did speak to the chair, knowing that we were meeting today this afternoon, just to get a date in our diary. So as we know, the government gave us guidance in short order to produce this strategy, and in conjunction with Jane at governance, we had penciled in a date, and I did confirm this morning that we will have a draft strategy that we can bring to the board, and as chair of this board, I will be bringing forward a special meeting on the 13th of December at 2 o'clock, was it, Jane? Sorry, did we have 2 o'clock? On the 13th of December? Was it 2 o'clock?
That's correct, Chair, 2 o'clock.
Thank you. That will be an in-person meeting because we will need to confirm the strategy. So we will need to have that meeting in person. I would ask that we diarise that, and if we can prioritise it. I appreciate diaries fill up and that is short notice on a meeting, on a special meeting, but it does give us, we have to have the joint strategy signed off by Christmas, so this is a kind of ideal date for that. So that will be the 13th of December, and if we can confirm that meeting in the minutes, please, Jane, and also if you can go about confirming that and make it so, that will be fantastic. Mike, over to you to come in.
Yeah, thank you, Chair. So just in relation to that development session this morning of the Health and Wellbeing Partnership, formerly known as the Integrated Care Partnership, I mean, I won't go into the detail of what we discussed a lot around the cost of living crisis. I guess the important thing for me is it's a bit of a test case for the Health and Wellbeing Partnership of sitting down with an area and then working through where does the real action lie, which I think everybody seems to say was basically based around the upper tier authority. So for us, it would be this board and Rutland. But then what can the Health and Wellbeing Partnership add in terms of sort of pushing things collectively across LLNR, particularly those organisations which are bigger than Rutland, the police and fire being two obvious examples. So I haven't quite got the words right in my own mind, but I thought it was good to work through a topic just to see that there is a role for both boards and not trying to end up thinking actually the ICP Health and Wellbeing Partnership is just duplicating everything that happened at Health and Wellbeing Board. Clearly, I think this morning there were some sort of specifics really in terms of how could we take the services that provide support to residents in Rutland, but make certain that the NHS through things like social prescribing is both promoting them to residents, but also promoting them to their own staff as well. So hopefully useful, but I would suspect more detail at our next meeting.
Thanks very much, Mike, and yeah, thanks for bringing it together better than I was there on what happened earlier. I think that kind of oh, sorry, I've lost myself. I've turned the page and now I've lost. So we're going to note that update, and then we will move on to item 11, please, which is the Joint Health and Wellbeing Strategy. It's a report presented by Catherine, who's taken over the role as Health and Integration Lead, as I said. What I would say before, this also is the part that goes back to the action that we carried forward, I think, as well, isn't it, Debbie? It is that bit. So what I would say from myself, this doesn't quite do it for me, and I don't know if other board members agree. I think one of the things that the board needs to be able to do with regard to our plan, is to measure ourselves against targets and to see how we're progressing, and as a board be reassured that the items in the plan from the strategy are moving forward. I'm not sure we've got that quite right in this, and we don't have, obviously I'm aware that moving on we've got larger things on the agenda that are more interest to our public. So I will come to Catherine to just pull out some highlights, but what I suggest is that maybe Deb, Catherine, myself, possibly John, we have a meeting outside and just have another little hatch at getting this right, because it's important that we get it right for all of us to move forward. And I'm conscious that we don't want to make lots and lots of work for our leads on here, but equally as a board, we need to kind of see. So I don't think we're quite there. Deb, did you want to come in quickly?
Just very quickly, I think it's a good idea for us to meet outside. I would just like to make one point, just certainly for the board members and the public. This is an action plan against a 5-year strategy. So we are in month 6, in year 1 out of 5 years. And so, because we did a lot of discussion and reflection on this when looking at the actions, it's quite difficult this early on to see movements in outcomes across that period of time. Having said that, we need to make sure that certainly you as chair and the board and the public are getting the right form of assurance across the piece. So I think a meeting outside would be helpful, particularly as we would have liked to have done that before the board, but because of the change in personnel, we didn't get a chance to.
Thanks, Deb. Catherine, I don't know whether you want to come in and raise a few highlights, if you're happy to.
Yes, I wanted to try and cover a range of priorities. I wanted to highlight around cross-cutting theme, mental health. Rutland has successfully appointed to the role of senior mental health neighbourhood lead, which is to lead, transform and develop the neighbourhood network to deliver improvements to mental health in Rutland. So that's happened over the last quarter. And the mental health neighbourhood network group commenced with their first meeting on the 7th of September. So that's now going forward and the terms of reference are being worked on. In relation to priority 2, the social prescribing platform Joy is now in place and it's currently being used by the RISE team. And the platform enables professionals to link people to local services, and people will be able to self-refer and find information about services and activities. On priority 3, the WASAN pilot, I hope I've pronounced that right, has commenced with the 9 Rutland care homes. This is a blue box and it's an all-in-one telehealth case, which enables staff to measure vital signs, record photos, and also ability to perform different assessments. And the aim of this is to be able to identify deterioration or illness in a resident at an earlier point for whatever appropriate clinical or carer response. So that's been brought in the last quarter. On priority 4, the PCN has started its enhanced service, which began on the 1st of October. So this is a rotation on a rotational basis across the 4 GP sites. And this is for pre-bookable same day access, which is Monday to Friday evenings and during the day on Saturday. And that's all really to focus on prevention and obviously promoting get a better access to that service. That started. We also have 180 blood pressure monitors for use now across the 4 practices, which supports with ongoing monitoring and review. And just to say also within priority 5, there's been a successful recruitment. I know this has been discussed before, of the 7 clinical pharmacists. And this is part of an innovative academy in partnership with Nottingham University. And this is around improving access for cardiovascular disease, risk management and diagnostics. So I hope I've provided a range of positive updates that have come into place over the last quarter.
Thanks very much, Catherine. Janet.
Thank you. Thank you for the report. I'm just wondering, I've noticed that there's a scheme going on in the care homes for falls prevention. And obviously that's very valuable because there's a high proportion of at risk of falls people in these places. But I'm just wondering if there is any data out there that actually shows where the most falls occur, whether they're out on the street, whether they're in the home, or whether they're in care homes. And are there any measures being taken to protect people from falls or to help people avoid falls in their own homes? Because there's more and more of a move to keep people in their own homes rather than in care homes and in hospitals. So I just wondered, that's all.
I'll bring John in because I know he's got the answer to this. And
Yeah, thanks, Chair. Certainly there's an initiative that's been going on for quite a few years across LLR with health and social care, looking at falls and falls prevention, and that's ongoing. Specific to the local authority, we've got our own team of occupational therapists, and we also have what's called the housing MOT that's contracted out for us with Longhurst. And what that is, that's people going into people's homes and literally doing an MOT of the house if there's any trip hazards. We're starting to talk to the fire service as well, so they can become involved and we can have a look at fire hazards. That's an example of how we're starting to work in a more joined up way. So yes, this is an area that we're quite on to. Catherine, I don't know if you've got anything else to add to that.
You will have seen in the report that we're really working hard to work with residential providers to get falls champions within their homes, and there are now 2 in place in 2 of the Rutland care homes, and the therapists are working hard to expand that scheme because, as you rightly say, there are so many issues regarding falls. So that's the provision within residential care. I can't answer the question around statistics, but I can try and find out. But yes, as John said, our therapists really link up with assistive technology, and obviously provision of equipment to minimise falls in people's homes. People working really hard on that.
thank you. James, did you want to come in on this?
Yeah, I think the PCN actually, I forget which pot it was, but we put in a bid for targeting patients who might be at risk for fractures from who have osteoporosis, and link them up with funded places for the Inspire to Try Manton Hall for we called it Stable and Able, which was about trying to make people improve their mobility and less likely to fall over. So I echo the probably the lack of data around where falls are happening most and how they get reported, but we've certainly done some targeting of high-risk populations, and I think data would be very useful to compare across all of the care homes and housebound population. That would be great.
Thank you. I've got James, James, Janet, then John. There's a book there, and And then I'll bring this swiftly to a close, but I do have a recommendation. So Janet first, please.
Yeah, thanks very much for the replies. My concern is that with the House MOT and with the PCN identifying people, there may be a lot of people at risk who aren't coming forward to ask for House MOT because they're worried about costs or disruption, or they're suspicious of something. And the PCN is obviously flagging up people with a known condition, you know, with osteoporosis, etc. I think there might be a lot of people approaching their latter years who are at risk and going undetected and then falling and fracturing their neck or femur or whatever, but I don't know. So I just wanted to flag it up, really.
Thanks very much, John.
Yeah, it was just to say, and this might be part of your recommendation, Chair. We've got a principal occupational therapist in the council that's quite expert on this and is well plugged into the LLR falls prevention agenda. It might be worth Catherine perhaps having a chat and just see if there's any data that's available that way, because I'm quite sure there will be some there, because this is something that's been going on for a good couple of years or so.
Thanks, John. That was my recommendation. Not so much the person, but around the data. If we could, Jen, make a recommendation or put an action for this, that we have a look at to see whether there is falls data available for us, and for that to bring back to the board. And it may be that we seek to just get some more information, maybe a briefing to board members would be helpful. So not a full agenda item for next time, but perhaps a briefing to members. And then if we wanted to take that further, perhaps we could look at putting that in a future agenda. If we're all happy with that, I'm not getting any shake, so I think we'll move on. I'm desperately trying to claw some time back now, Catherine. So item 12 was Better Care Fund, and I was going to go over to Catherine to give a big detail on it. However, if it's okay, I'm going to take the report as read. And we were to note the content of the report and to note that the submission has already been sent to the national team on the 26th of September and has been signed off. I don't know whether Catherine, if I'm quite happy if members of the board are, that we just take some questions, if that's okay. But I appreciate I'm stealing your thunder on your first big thing, Catherine. So I apologise. I think Deb wants to come in, but I do desperately want to call back some time if that's okay. And because this is very much a kind of noting. Deb, I will take your question. So if members have questions on the BCF, please do.
Apologies, Chair. It's a comment rather than a question. I was also struggling to lower my hand, but obviously this BCF is been more or less a rollover from the previous year, but the next submission will be a 2-year submission, and a lot of the things that we've talked about today, even sort of the latter one on falls, on dying well, if you'll excuse the expression, councillor, are things that we can look at future BCF submissions on, because we spend an awful lot of money around delivering services, and so a lot of the achievements are highlighted in this report, of which there are many across a lot of the domains, have been funded and driven by the BCF. So we need to make sure that our next submission takes into account some of the areas that we've highlighted in the strategy and in our conversations, to ensure that we make the best use of that joint resource.
Thanks very much, Deb. Are there any more comments, questions?
Just sorry, Councillor
No.
Harvey. Yeah, just to absolutely agree with you, Deb. What I want to do going forward, next steps, is pick this up again over the next few months and have a really coordinated, integrated approach around it, and keep it as a rolling piece of work. So absolutely, any any new ideas and new pieces of work that we can use the BCF money for, that's very positive. I'm really happy to lead on that.
Thank you very much indeed, Catherine. So if, as a board, if we're happy, then we'll note the content of the, we'll note that we have done the submission. I would recommend people do read the report and do, it does highlight the good work that's been done. And as you said, Catherine and Deb, we will take on board and move forward with it, integrating all these new pieces of work. And thank you, Catherine, for allowing me just to kind of quicken over it. I do appreciate it. Item 13 is our update from subgroups. If we can have a brief from Councillor Wilby regarding Children and Young People's Partnership. He's going to give us a quick 5 minutes.
Thanks, Chair. I'll be as brief as possible. Generally going well. I missed the last meeting last month, but I have had the update. A good rapport with all partners who are all trying to do their very best for our children. Much churn throughout our organisations, which is causing some delays and extra difficulty. There is a constant chase to keep the audit trail of regular checks, but we are getting these back under control to keep the data analysis on track. Good school attendance figures, but some increase in behavioural and pupil concerns across the board. Some minor drop in reading and writing at primary schools, probably due to varying levels of remote learning supervision, but excellent results at GCSE and A-level exams. Some increase in behavioural and pupil concerns from schools. I think I've said that already once before. Notwithstanding, we have just had a very positive peer review of our SEND organisation, which was gratifying and gave the staff a bit of a lift. The development of the family hub is progressing, and I keep pressing for more children's and parents' voices being generated for our various meetings. Work with UASC is going well, and many of our folk are now entering post-16 courses and doing well. Some 37 Ukrainian children seem to be coping well, and they are spread throughout all our schools and developing good community links. Overall, as might as be expected, given the challenges of the last few years, and we continue to try and improve our performance.
Thanks very much, Councillor Wilby. Do we have any questions to the Children's Partnership? No. So over to you, Deb, for the Integrated Delivery Group.
Thank you, Chair. And actually, most of my updates already been covered as part of the agenda, but so I'll just quickly whiz through it. We've had agreement to establish a Staying Healthy Partnership Group as a subgroup of IDG, and the first meeting of that will be in November, chaired by Public Health, and we'll focus on 2 priority areas: staying healthy and independent, with a focus on prevention and reducing health inequalities. And we've obviously touched quite a lot on that in the meeting today. We've had 2 key staff changes, and I would just like to formally thank both Viv Robbins and Sandra, who have been instrumental in developing both the strategy and our plans and the work to date, and to welcome Catherine and Adrian, as you mentioned earlier. There's a lot of work for us to do going forward. We did spend quite a bit of our time looking at our reporting structures, and I think having the meeting outside will be helpful, because what I don't want to do is for us to go forward spending a lot of time working at reporting and not the time delivering on the actions. So hopefully we'll see some progress in that in the next month. We need to review our actions of our plan against our 5-year strategy and take into account the health needs assessment, And we also need to put some focus on our communication and engagement plan, because we've had sort of a gap in that with the change in personnel. Thank you.
Thanks very much, Deb. So we've got just one, and this is a bit of housekeeping with regard to the subgroups. So Jane and I were looking at governance and looking at our constitution that obviously has gone through full council now. And we need to, as part of that governance, we need to just have the terms of reference of the subgroups agreed by the board. If we can add an action, Jane, for the terms of reference of the two subgroups, just to be quickly updated. I know IDGs were updated in July of this year. The Children's Partnership, we just need to do that. They were updated in June 20, and they just need to bring in the strategy slightly. So they just need a little tweak, they do, to come forward. And if we can then look at seeing them in the January board, which will be in person, so we can agree those and sign them off, and then we've just got our housekeeping in order, if that's okay. So that will be our update. So next we go on to item 14, which is our health update. Firstly, our primary care update. We have it from our Vice Chair of the Health and Wellbeing Board, James Burden. I would like to say thank you for agreeing after we voted you in your absence. We do appreciate that you accepted our offer. And you're going to be covering the changing landscape to primary care workforce, the enhanced access plans that have been mentioned, and the outcomes of the recommendations from the primary care access task and finish group. So over to you.
Lovely, thank you very much. Now, so I'm just going to try and share the screen. So please tell me if it's not working.
Over there.
Can you see? You can see the presentation now. Then explaining the evolution of the GP practice workforce at national, local level.
I do. You just need to start press the start slides button, and then it goes from. Then it will become full screen.
You can see that.
We can, yes.
Lovely. So I'll try and be as quick as possible, and overall explaining some of the basics. GP numbers across the UK, the Health Select Committee in the primary care workforce, contractual opportunities from government contracts. That links to enhanced access, which I think there's we'll cover in a separate bit for this. The R's role, explain what that is, and the Rutland plan for GP practices and the R's role, and the ethos of free at the point of care, appropriate to need. So fundamentally, some of the basics. GP practices are funded with a contract through the government. Most are GMS contracts, which effectively means practices are meant to cover 5 days a week. There are some APMS contracts, which are 7 days a week. But Rutland basically has GMS 5 day a week GP practices. Within those practices, there are GP partners, let's call them directors. They're not technically directors, but they have the ability to recruit staff such as salary GPs, nurses and healthcare assistants to help them deliver on the contract that they have. Practices receive some of their core funding and attract extra funding based on performance indicators, commonly known as QOF. QOF indicators are negotiated by the government with the BMA, or effectively the GPC, which is the BMA negotiating arm. And this covers things like blood pressure targets and cholesterol management and other bits and pieces. So it's certainly not locally or even LLR agreed. It's a national contract. The opening hours of a GP practice are traditionally 8 till 6:30, Monday to Friday. So it's not just me. The Health Select Committee says that I'm getting older each and every year, like all of my colleagues. And there are problems with that, in that an increasing number of GPs want a varied career, and that's from the moment they graduate say, working in hospital clinics or being the chair of a health and wellbeing board. Some want to be locums, and some are driven into retirement through pension considerations. So the historical workforce planning for a stable GP population was made some 20 years ago. So I took 5 years to go to medical school, a year to be a house officer, 3 years to train as a GP, and then you start to say the first 5 years of learning to be a GP. So certainly at least 8 years, 9 years, from the moment you enter medical school to actually you're the youngest GP in the county. So it takes a long time to plan for these things. Actually, GPs now, even the Health Select Committee says this, they're delivering more appointments now than they've ever done in the past. Hospital consultants are working incredibly hard, have been heroic in the COVID pandemic, but in general, there's an increase, certainly compared to 10 years ago, there's an increased rate of discharging patients back to the GP care rather than, for example, following up somebody with diabetes in the diabetes clinic or even cardiology from that point of view. So there is more activity being put into general practice, as well as an aging and reducing population of GPs. So there was something called the PCN, Primary Care Network DES, and the Primary Care Network DES is effectively a contract extension. This is national, not just local, and it basically brings together the 4 practices, there are 3 partnerships, but 4 practices of Rutland to deliver services in bigger units of healthcare. The businesses have not merged, but it's effectively a way of bringing in practices together to deliver the contract, and the contract is very detailed. But what it allows us to do is recruit new clinicians to roles that effectively size brings the opportunity to recruit new members of staff, like physiotherapists, or in fact diagnostic physiotherapists, specialist nurses, and teams within an area. And these teams that are employable through the DES is called the Additional Roles and Reimbursement System. So that's ARS, A-R-R-S. Now, the ARS contract extension is a very, very, very good way of funding GP practices, in my opinion. In that, practices are only reimbursed for the staff that they have successfully recruited. So this is not a practice who gets given a budget and can keep all the money. They only get reimbursed if they employ new members of staff. There's a limit on the budget that you can claim based on your practice population or PCN area. And there's also limits on the numbers of types of different staff that you can recruit. For example, you couldn't just go and recruit 20 new ambulance workers, because it would probably leave EMAS, East Midlands Ambulance Service, with no ambulance staff. So they did it in a very gradual, structured manner. And there are 27 PCNs in the LLR area, and all the PCNs are generally competing for the same staff, in that there is not so we're all competing for the same staff. And realistically, each year there are new areas that practices can claim income for. When I say income, funding to employ new members of staff. There's no profit in this service whatsoever. Effectively, there's a whole list of things that we looked at, and it also links to the fact that the general practice in England, as part of this, we're expected to deliver the enhanced access longer opening. And that means somewhere in the PCN, so one of the practices has to be open Monday to Friday and Saturday morning. So this we heard earlier, where it started in October with appointments being offered on a Saturday, and that is not in all practices, that's in one area of the PCN. So for us, we rotated it round the different GP practices, and the numbers are that there needs to be 44 hours of work for 44,000 patients of Rutland. Importantly, it's not a GP doing all of those hours. They need to be available to GPs need to be available to supervise the staff, and actually the GPs locally said that they would all be in the buildings for this supervision, and it wouldn't be remotely from home or anything like that, which technically is allowable, but we didn't feel that was appropriate. So the issue around this builds to the expectations of only seeing a GP, and I think the fact is that that has to change if we're then looking at lining with what appears to be the national governmental strategy for workforce planning in the UK, sorry, in England. The issues are increasing amount of access, continuity of care with your GP versus reducing numbers of GPs, and they are staff that are there to help GPs deliver healthcare in a business. So when patients want and expect to see their GP and only their GP, this is really good. It drives up satisfaction for both the GP and the patient. But then the problem with that is it limits the number of people that you can actually be seen or delivered by the NHS across the system. So the R staff enables many of the activities to be delivered that traditionally are called GP substitution roles. And so, for example, what can these do? Well, a clinical pharmacist, this is somebody who's done a degree in medicine and is working in primary care and can prescribe medications independently without having the GP sign it off. They can review high blood pressure, cholesterol, emphysema, asthma, and when trained, they can see people for minor illness such as urine infection, chest infection, skin infections. We've got employed mental health practitioners who can manage depression, assess suicide risk, and first contact physiotherapists who are effectively physios who've trained to be diagnostic as well. So this is the equivalent of seeing a GP or an orthopedic consultant in clinic, i.e. this is your diagnosis, this is what I think is going on, this is what we should do. So it isn't just about seeing the GP, and the workforce contract is about expanding the number of people working in GP practices and not just the, in fact, you're not allowed to, there's no funding available to recruit GPs with this budget. It's all associated medical practitioners. So the Rutland is lovely. I truly believe it's lovely. I'm now working here and I think it's fantastic. But there is a genuine NHS workforce crisis, and the Health Select Committee has brought that to the fore of everybody's minds. The local practices have advertised for GPs and have had some applications, but some practices have had no applicants for years, despite the fact that they've advertised. So what we wanted to do was we had to compete against other PCNs, primary care networks, and look to develop roles that will help us. And we've done this. We called it the Rutland Clinical Pharmacy Academy, and that has been very successful in that we have managed to utilize government funding for the recruitment of 4 care coordinators. One of them was effectively a project lead or project delivery person. One of them was a Ukrainian doctor who's helped all age groups of displaced Ukrainian patients, who is not working as a doctor. They're working as a translator and a healthcare assistant and a care coordinator. We've got 2 care coordinators who have done a high-risk prescribing project where we've been shortlisted for the HSJ Health Service Journal Patient Safety Award, which is very prestigious. We've got a health and wellbeing coach, diagnostic physiotherapist, that's the first contact physio, mental health practitioner, and we'll have 10 clinical pharmacists in this Rutland Academy. Now, 7 of those new clinical pharmacists, using the National Apprenticeship Scheme, will go off to Nottingham University 1 day a week, that's 20%, so 1 day a week, to become diagnostic clinicians. So not just managing diagnoses when they've been made, when a patient's got established COPD or asthma or blood pressure, they would be seeing people to diagnose it in the first place. And this degree is a 3-year course. So all of this is about creating a workforce that really is likely to be here for at least 3 years, depending before they might graduate to then work in other areas or hopefully stay here. How have we used the money? We've employed the people to increase access. We've done some social prescribing work with the RISE team, and which was my meeting before this, which is just fantastic to help integrate care and deliver it between the gaps between organisations. The ethos of the Rutland Health Offer is, well, I mean, in the NHS Constitution, it starts with free at the point of care, appropriate to need. So we're going to increase, we are, and I don't want to I appreciate this is blowing our own trumpet, but there are lots of PCNs who have not managed to fully utilise their budget. There's lots of PCNs that have not managed to recruit staff to fill their posts. If you don't recruit staff, you can't claim the money. And I think we've been very successful in actually fulfilling our workforce plan, utilising every penny that's available from the government system. So we've increased the number of clinicians. There will be diagnostic clinicians through the master's degree. We've increased productivity of GP practices by using interactive text messaging. We're increasing the safety of systems by using care coordinators to target population groups in the health inequalities. We're trying to get people to improve their self-awareness and self-care by using blood pressure machines at home or borrowing them from the practice, because they're averaging their blood pressure at home and sending in the numbers is more efficient than them coming to have a 1 or 2 readings with the healthcare assistant. And we need to then advertise the role of these GP substitute clinicians, because the Health Select Committee has shown the fact that the numbers of GPs are going to go down and down and down, and it will take at least 8 years to correct this, even if the numbers of people in medical schools are increased now. So with the Rutland Clinical Pharmacy Academy, I believe that we are delivering a workforce that will help stabilise the local offer from that point of view. So we are using every available pound of the R's budget to deliver care and improve access. The technology element of this is very important, because it is quicker to send text messages, and as that improves the ability of the GP to see more people than they would traditionally do by just phoning people. We're all working with secondary care and the ICS to improve services from the backlog from the COVID pandemic. There is lots of problems with the local estates, because fundamentally we've increased the workforce by something like 15 clinicians, and there are not 15 extra rooms. So some of the clinicians, the clinical pharmacists, will have to work from home on laptops, but they will rotate round so they all have a fair share of seeing patients. This isn't just a Rutland problem, and it is a GP practice that is effectively a modern GP practice. It's not like it used to be, but the government contract is directing us to employ clinicians this way, and we've been very lucky that we've managed to actually recruit really high quality clinicians to do this masters, utilising the apprenticeship scheme. So this is an issue that's affecting the whole country, but overall this presentation tells you what's happening nationally and then locally as to how we're using the funding that's available. Any questions from that? I think after this I'll probably go on to talk about, there's 2 other presentations really, the enhanced access, and I can talk about that, and the patient access work group, task and finish group that was set up. Do you want questions on this now, Chair? We're on mute.
I'm on mute. Shall we move on? Save you closing down because I can't see hands very well. Mike's got his hand up because so Mike's going to come in with a question.
Yes, thanks, James. That was really interesting. I don't know if it was a comment, a question or a comment, but I suppose I'm looking at what's laid out in the R's plan, and it's not just about providing people to let's get my words right. Fundamentally, I'm looking at thinking what's not said, unless I missed it, is how the workforce that's being put in place really responds to the shift in a GP's work from being a kind of traditional family doctor where people would turn up with their ailments, not that there's still an awful lot that goes on, into a workforce that's really dealing with complex long-term condition management, of which there's a variety of schemes and funding which is put in place, really specialist clinical diagnostic and everything else you talked about work. But I sort of wondered if nationally, locally, we've got the narrative right about this isn't just about saying you can't go to GP because there's not enough of them and therefore we've given you another option, but fundamentally is recognising that the workload of a GP has changed into a more specialist long-term condition management kind of model. It's almost like we've not, unless I've missed it, we've not talked about the model, but we talked about some of the kind of specifics of what we're doing in response to that changing thing, if that makes sense.
So I think, I mean, some of the, over the years, the, I wouldn't say guidance, but the protocols of how blood pressure and COPD and asthma should be managed means that actually many of these long-term conditions can, there is actually very little variety of what should be the next step in somebody's medication given certain scenarios. So I think it's a very effective way of using clinical pharmacists, and they'll be doing much more than just blood pressure. They're catching patients after they've been discharged from the hospital, making sure their medications are aligned, releasing GPs to be doing less administrative duties and effectively being available for patients. I think they will, they are brilliant, the clinical pharmacists we've recruited, and I think they are itching to see patients, and I think it will be brilliant for them, for patients to be able to see that actually this bigger workforce can help urge their healthcare in the right direction. I think where the modern GP goes and where do they sit is they're effectively supervising a whole MDT of staff. And so some of it will be seeing patients, and that might be the palliative care patients that we've talked about already in the Health and Wellbeing Board, and some of it will be the uncertain diagnostic patients who need a generalist with expertise in making that diagnosis. And I think we will shape it. It's hard to say exactly because we need to then look at how well the clinical pharmacists do, but actually using Nottingham University to do that and the masters, this is a very high class university who is really excited about the project and delivering education in a way that is far better than if we said, well, we'll do a tutorial in the afternoon. They're going to graduate as a master's person, and that look, and the fact that we're doing this, you have to start to gain a reputation. So if somebody does leave us in 3 years' time with a master's and go on to do something else somewhere else, there'll be other people who come through because they heard that the Rutland offer was really good, and we develop our workforce. So people might graduate and leave, but that's the fact of life. What we want to do is build a reputation for it to be a really great place to come and work and learn and live. Deborah.
Thank you. Mike, you raise a really important point, and I think we need to work with the comms and engagement strategy to underpin some of this, to work with the public, to talk about the different roles, because I think even if there were lots of GPs available, that the way in which care is developed and the conditions that are dealt with in the community have changed quite significantly. So you've gone away from just a single clinician-based service. We wouldn't want to deliver all of that care with only GPs, because actually there's now a range of staff available. It's becoming somewhat akin to hospital care. When patients go to a hospital, they're not, very few of them are actually seen by the consultant for the majority of their care. They oversee and sort of coordinate that clinical care to patients. So I think that there's a job certainly for the Health and Wellbeing Board, for us as individual leaders of parts of our organisation, to work and to work with Health Watch and some of the patient groups to inform about all of these different roles and how the different range of care options there are dependent upon the needs of our population.
Thanks, Deb. Janet.
Yeah, thank you, Deborah. As Health Watch, we've been trying to inform the public about these additional roles for quite some years now. I do have to say that we're still meeting quite a lot of resistance from the patients, from the public. And so I would like to reinforce Deborah's message. We still need much more comms and engagement with the public for them to understand that they won't see a doctor every time, and they don't need to see a doctor every time. They can see alternative people. We're having an awful lot of problem getting that message out there, and this is feeding into a frustration and lack of trust, spoilt relationships, etc., all the way along the line between doctors and their patients. I feel, we hear comments like, have the doctors all gone on holiday? Where are they all? Don't they work now? This sort of thing. And I know that's not the case. And I know that doctors are very stretched and working very hard, but there seems a mismatch in the messaging. And we've tried to sort of get it out there, but it still persists.
Apologies, the dogs are off again. I would say, and I'd kind of challenge back to us all as members of the board, that actually it comes down to us to actually challenge some of that thinking and to challenge it when we hear it, and that's all I can say. We're all part of trying to change that message, and we can't just leave it to our colleagues in primary care to have to change that message. It does kind of come from all of us, that hopefully we can do that. And I do think there are some changes, and people are. It depends. I think it's a generational thing sometimes, in as much as some people are more used to one particular system. Some people embrace the kind of newer times and the ability. Sometimes that gives more flexibility to people and with busy lives and things. So, but I think we do need to, all of us, challenge some of the narratives that we hear, and I would challenge all of us on the board to do that. Sorry, James, you want to come back, and then I am very conscious of the time. We've still got loads to get through, so if we can bring this one to a close, and then we'll move on to your next bit.
So I think the wonderful bit is, this is permanent members of staff who are coming to work in Rutland for at least 3 years, and they are the creme de la creme, advancing their careers by doing a master's, and we're using every available pound. But the government workforce recruitment strategy, and I think it's a very good way of improving the numbers of clinicians in primary care, is a national strategy, and we're doing, I believe, very well to utilise that for free care at the point of delivery appropriate to need, and that how we get that across, I think, is important. If I then move on to
we just got David who put his hand up just briefly, so we'll let him come on, and then you can move on.
It's just an observation, really. I guess we've got to do something, haven't we? And this sounds like a very positive step. I just hope time will tell how it works out, but experts have come up with this as a way forward, and I think we should look at the process, in the manner to which it's given. Go ahead and give it full steam, and make sure we do it as well as we can.
Thanks, David. James, would you like to move on?
Yeah, this will be very quick, I think, because we've probably done some of this. If I can have your guidance again as to whether you can see the next bit of this presentation, enhanced access.
Yeah, we can see.
This is about informing what it is, and we can talk about it. It's part of the DES contractual requirement, and it started on October the 1st. So it's a almost perfectly timed Health and Wellbeing Board for this. Effectively, this practices will be open 6:30 till 8, delivering some care Monday to Friday. A practice, not all practices, and a practice will be open on a Saturday 9 till 5. There is no walk-in appointments, they're scheduled appointments, and the building will be open on a Saturday from that point of view, but it won't be a full service. It's not commissioned to be a full open practice from that point of view. Actually, I just want to come to almost like one bit of this. We put out a survey, the Enhanced Access Survey, that was actually the Health Watch and the PPG chairs really helped us refine the quality of this, the wording and the survey. And it was about asking patients what they wanted for this, these hours. And we got 9,000 responses in a 3 to 4 week open survey of, I mean, there's 44,000 patients and not all of them can use the computer because they're under the age of 5. 9,000 responses, which is really fantastic. And it basically helped shape the services that we'll be offering. The acute care services at Rutland Memorial Hospital remain unchanged, but basically the practices will vary in this rotation. So it's generally easy to remember. Oakham will be open, or the Oakham part, it will go open, Oakham, Uppingham, Marcus Overton, Empingham, whereas remote GP practices on a Friday and then rotating in the same sequence, Oakham, Uppingham, Oakham, Empingham on the Saturdays. And they've gone very smoothly. For the launch of a new system, it's actually gone very smoothly. The Saturdays are delegated to a provider company effectively. So staff who want to work at the weekends, cost of living crisis, etc., can. And that will be delivering some long-term condition work, such as having your blood taken on a Saturday because you're working during the week, or nurses to do smears and diabetes reviews, or from that point of view. And GPs through the week will be doing complex care reviews, palliative care reviews, cancer care reviews, with clinical pharmacists reviewing those medications we've talked about with long-term conditions. And effectively, it rotates around on the weekends. So all the practices are engaging in this. There's been no opt-outs. We've got a service that's obviously will be refined as it goes, and we can communicate more and more as to how it goes. I actually really want to thank Health Watch and the PPG chairs who helped shape that survey. And I think 9,000 responses is, I was blown away. I was on a holiday actually at the time when it was out, being elected as this vice chair in my absence. But I heard about the 9,000 responses, and I think it was just fantastic, really, in terms of how people are willing to engage from that point of view. I'll stop sharing now. Any questions on that?
I'll wait for hands. I've got one question in the meantime, if we're quick. Can I just clarify with regard to the different practices on different days? Do you have to be other appointments? So say for Monday's Oakham, Thursday's Empingham, are the days reserved for just those practice patients? So on a Monday, or can any practice book into any of the sessions?
technically any patient from any practice can book into those appointment slots that are in the various areas. So they should be available to be bookable online at least 2 weeks in advance. I think in general, most patients want to be able to see their GP, and that would probably be most satisfying for the GP and the patient if they can see their patients. Certainly the Saturdays where it's if you're things for ladies who are having cervical smears and some of the diabetes reviews, that can because it's being the way it's being provided, actually there's inherent less continuity from that point of view. And so patients from Rutland can go to technically to any of the practices or that are open at that time for any of the services.
Thanks, James. Any other questions at all? David.
Sorry, I have to ask the question as I come from the Eastern approaches. What about the tie-up between those of us in Ryle and Essendine and everyone who tend to go to Lakeside at Stamford?
The enhanced access is within the PCN. So if your GP practice is in the Lakeside PCN, then you'd be accessing healthcare through your registered GP practice. So it's still healthcare delivered by the registered practices. So if you are registered with Oakham, Empingham, Market Overton and Somerby and Uppingham surgeries, you can book appointments in the Rutland Health PCN enhanced access. If you're registered in other practices such as Lakeside Corby, Lakeside Stamford or Bilston, you would be accessing healthcare through the PCNs that serve their population. And these are the rules of the game, the contract laid down by the government.
Okay, thank you.
Thank you. Any other questions? No? Oh, sorry, Janet.
Yeah, it's early days yet, so I won't ask you about numbers, but it would be really interesting if everybody agreed, if we could have some indication of how many people are taking up and utilising these enhanced access appointments. I mean, you've had a little bit more time to actually evaluate that. That would be interesting for me anyway.
Absolutely, because I think the aim is to have every single appointment used when access is a problem. We need to make sure that every appointment is utilised and available. I agree that we can bring that back. I mean, there will be review and refinement of all the service, but yes, we'll bring that back.
Thank you. Do we want to whiz through the next thing? I am very conscious of time. We've still got 2 big agenda items.
I appreciate I'm on a roll here. I think if we were doing the GP access task and finish group, so I'm almost starting to be fluid in technology, so forgive me if I'm assuming that you can all see this GP access task and finish group. I did it as a presentation rather than as an update. Realistically, the foundations have been laid for improving care with the enhanced access starting on the 1st of October, 9,000 responses, 9 new prescribing clinicians. I say 9, one person had left, they've been replaced. We've got a supervising clinical pharmacist that's been appointed, and there's 7 new ones. So technically there is 9 new clinicians coming to the area. I think overall, I think the vital bit is healthcare is digitalizing, and that is a shift and a move from what it used to be like in the future, in the past, to what it will be like in the future. And there's an awful lot of benefits from digitalizing. The ability to share information, links, the Dying Well Matters website, to directly give that to people, and all sorts of other elements of interactive healthcare. But that requires mobile phones and email addresses for us to then be able to transfer information. So I think it's really important that we try and take every patient with us onto an online forum wherever possible, and then support any of the patients who can't and truly can't access online services from that point of view. So I think it's really important that we look to persuade people about the benefits of technology. And I don't think that we've always been brilliant at trying to persuade and having an effective communication strategy in this. So I think the PCN, which is effectively the 4 practices, need to work together with the PPG, patient participation groups, and Healthwatch to come up with a very good way of helping patients digitalize their access. And I think doing this makes it a more efficient system. I don't believe that's efficient for profits. It's about efficient for the fact that we can target populations. If we're trying to look at and target the populations who are not accessing healthcare, we need to try and make the other areas of the system as efficiently delivered as possible, so that we can do total population management. So some of this will be about submitting blood pressures online and doing it at home, and because that's much more efficient, or even sending in photos when people are able to, for skin lesions and moles. Certainly, I don't have great vision, but some of the pictures that are sent in by smartphones are much higher quality than I can see with my naked eye, and are really helpful. So there are some benefits from digitalization. So that would mean patients providing an email address that they use and a mobile phone or a number, or actually having an email address that's linked to their tablet device from that point of view. There's an effect for the patient and the surgery. So, for example, if I'm seeing somebody in a consultation, I can schedule a text message that will be sent in 2 weeks' time that says, can you let me know whether your indigestion has cleared up with these tablets I gave you? And that allows the patient to come back to me. It's a bit like medical WhatsApp, but it goes directly into the medical notes. And you can schedule that, which means when the patient says, no, it hasn't, I've still got terrible indigestion, the tablets haven't worked, the GP can then turn around and say, well, I'll phone you up, or I'll book an appointment. And the patients who have completely got better, the GP can say, that's absolutely brilliant, I'll put them on repeat for you, and it takes 25 seconds and move on to the next patient. If we're trying for total population management, we have to find ways that technology can help us, because the budget is not increasing, the workforce is only marginally increasing with the hours. So we need to use technology. There's very few businesses in UK that are trying to digitalize less. So I think there are lots of things that we can do. We can schedule a lot of the long-term conditions through the year to send messages at the right time for, say, their birth month, for submission of blood pressures, or take people through their asthma questions. We've had a higher number of people respond to the text messages to review their asthma than we ever were able to by bringing them in for a face-to-face review. So it's efficient, and then we can target the patients who have uncontrolled asthma or aren't on a digital access point. I think the practice websites need to become much more patient-friendly. And I think what I'd want to do is ask for help there around how we can manage that. That might be that patient participation groups, or patients with expertise in this, or Healthwatch or Rutland County Council help us. But I think we need the practices within Rutland to have patient-friendly, patient-usable websites that are much better than they currently are at the moment. And I think that's a major thing that we need to deliver. So I think moving forwards together, we should try and make sure that as many patients as possible are able to use the online forms of communication. We can do that by working with stakeholders, patients, the Rutland County Council, the Integrated Care Board, and Health Watch, and this creates a scenario that if most people are submitting their forms online, we can use our receptionists who aren't as busy to then contact the patients who are not accessing health inequalities, have problems for vulnerability, patients who are vulnerable or aren't able to use the online bit. So what we'd want to do is to be able to increase this total population management by making the able submit their forms online where possible. The other bit about communicating with practices, because some part of the health and the Task and Finish group was about feedback. I mean, I think 10 years ago, if we recruited, 5 years ago, if we advertised for a receptionist, we'd get 100 applications. If we advertise for a receptionist now, we get 3 or 5 applications. And I think part of that, I mean, the details out today about the rate of unemployed, it's very difficult. But if there are lots of negative comments online about GP practices, then it's highly likely that patients will choose, staff, potential employees might think again about working in a GP practice. So we want to have good relationships with patients. Negative impacts online have a negative effect on staff morale. Morale in a GP practice, if it goes down, it's harder to keep staff, it makes it harder to deliver a service, and it's a vicious circle of decline for everybody. So negative comments don't help anybody. Constructive feedback through the PPGs, I think, helps greatly. High effort and low thanks means people leave. And this might not be an easy message to deliver, but the simple fact is there are an awful lot of people that have worked very hard for 2.5 years through the pandemic. And we need to encourage them and reward them, congratulate them, and say thank you for the works they've done. And if we have constant barrage of negative comments for a changing system, it will not help staff retention, and everybody suffers. The practice directors, GPs, the staff, and the patients. So we want the systems to feed back in a structured manner. I think PPGs, Health Watch, surveys are very good. I think the survey of 9,000 responses has really shown us that if we use technology brilliantly, we'll be able to have brilliant feedback. And 9,000 responses is extremely powerful. The PPGs, I think, have been wonderful in shaping that survey. And that is, again, we need to then look at how we utilize them as much as possible. We've got lots of physical constraints. We've got staff having to work from home because there's no space in the buildings, but there is limited budgets to alter this. So we've got to work at ways of doing, I don't think there's an easy answer for that. We just have to accept that we're constrained within the buildings that we're in and find new ways of working. And judging success by surveying patients. Well, I think surveying patients is important, but I think we need to think about how easy is it for you to see your GP. It probably is, how easy is it for you to access healthcare, or how easy was it for you to have your blood test, or to how, because the other R's roles people will be doing some of this work from that point of view. So I think if we were comparing practices, it might be easier or better to compare other practices such as Lakeside Corby, Lakeside Stamford, Wansford, Bilston, who also, Melton Mowbray, who also deliver some healthcare to Rutland patients. But I think overall, the survey should reflect the fact that we're employing new R's staff. So if we ask the question, is it easy for you to see your GP for your cholesterol or blood pressure? The answer is probably going to be no, because the clinical pharmacist will be doing a lot of work on that area. But if it's about how easy was it for you to access your healthcare via the systems online and seeing the right clinician, I think that is, we've got to ask the right question. So I think overall, we've summarised the bits we've taken away. The take-home message is, I think, for the Task and Finish Access group is we want patients practices to work really hard to get patients to use mobile phones and emails as a way of communicating via a very good website. And we want to try and make it easy for patients to give us praise and good feedback. And when the systems are not working, we need that to come through the PPGs so that we can have it in a structured manner and improve together. I haven't got a questions bit on that, but that's the end of that section. Any questions?
Yeah, thank you. We've got David, sorry, and David was first, then Deb, and I'm just going to, this is really important, but I'm going to have to be really quick. I'm very conscious that we've got 2 other big items going on. So if we can have David and then Deb, please.
I'm sorry, this is probably a rabbit hole question, but just listening to you talk, one of the things which just occurred to me, and I'm not a Luddite, and I understand that we have to do something to deal with the backlog, etc., etc. But just from a conceptual point of view, how much is the interaction between you as a GP and your patient important to you for picking up the personal, individual signs, which helps in your diagnosis or everything else, that it's dealing with a person as opposed to a digital robot? How do you think that will affect the way in which we do business in the long term, or affect your ability to keep improving and understand the human being as you go forward? That's not it's a difficult question.
I think that's a really important question, because actually, if we get the system as good as possible or as better than it used to be, because we're never going to have it as good as possible, we're always going to say we're going to refine, then the issue is that actually you get the right member of the workforce doing the right activity, and you can move some stuff away. So things like measuring blood pressure and optimizing control and numbers, which is effectively total population management through numbers, is how you increase life expectancy and other things. But if you can do that in a workforce, then what that does is it leaves the GP, and the quote is, reducing the admin, the GP to actually focus on the diagnostic elements of consultations and involved in the important elements of healthcare planning, which might be decisions of when to be admitted or stay at home for palliative care or the last 12 months of life. So I believe you can have both. I believe that if you do proper workforce planning and processes, you can move a significant amount of work away from GPs, that says GPs can be seeing more patients than they weren't before, and importantly, more face to face. Because I think it is the question when somebody's got their hand on the door handle as they're about to leave and say one more thing, or the hesitancy when they answer one thing and it leads to a disclosure of domestic violence or abuse, or mentioning what might not be an important thing like coughing up a small amount of blood it leads to a diagnosis. I think I love seeing patients face to face. I think we all love seeing patients face to face. And if workforce planning and processes does that effectively, we'll automate as much as possible for the raw statistical type of interactions that are targets, and leaving humans talking to humans.
Thanks, James. Deb?
I'll just add a little bit to that before I quickly ask my question or make my point. So I think, it is a really important question, but that's part of the R's roles and some of the proactive monitoring and prevention work that's part and parcel of our plan is to get as much information available on the health and well-being of patients available for the GP when they have that face-to-face appointment. And so having those interactions, the care coordinators, the sort of mental health facilitators, the RISE team, the care workers, all of the people who interact with patients and individuals will be gathering pieces of information, and we do, James does have, and I think he alluded to it earlier, they have integrated team meetings around specific complex patients where different individuals feed in around the care and needs of that patient to get that overall holistic view of patient care. So I think we need all of those things. But the point I was going to raise was around sort of digital inequalities that might be in place, and we need to be able to, the more people who are able to book their appointments digitally, if I can get the words out, it will help those patients, because actually booking an appointment online is quick, it's easy, you're not waiting. But there are groups of the population, and we've heard about it in the health inequalities, and also in terms of poverty, that won't have access. So we need to be able to join some of these dots and make it easier for those patients to actually ring for an appointment if they need to, if they've got no other access. We also need to look at ways, for example, facilities in libraries, in cafes, in sort of crisis cafes, and all of those things to allow access digitally, and potentially provide some training as well. So there's lots of initiatives that have been picked up as part of the integrated care team, which is a group of volunteers and voluntary agencies working with health and social care to pick some of these things up. Okay.
Thanks, Deb. Have we got any more questions or comments? No. Thanks so much, James, for that really comprehensive briefing across all three parts. That's fantastic. We're going to move on. I think, Deb, you're up next for B. Again, I'm just conscious of time, and Jane has already given me the nod on extending. So if we can, if we'll give a quick run through for you, Deb, if that's okay. You're next on the diagnostics, outpatients and elective, that's standing in for Helen Mathers.
Yes, so this is a late stand-in, so I'm not able to put the slide up. So she was going to talk around the slide. I've got a few points to make. Hopefully you can all see access to it via your packs.
I'll just say it's page 253 if people need to get their packs.
Thank you, Chair. So in terms of diagnostics, there will be the development of an East Community Diagnostic Centre within LLR. The business case will start in 2023, and with a view of it being operational by 24-25, which might seem a long way away, but it's part of a national strategy of introducing community diagnostic centres. Or somebody's been very helpful and putting the slide up. Thank you. 7-day working will be aimed in a planned and phased approach relative to demand. So that East Community Diagnostic Centre is likely to be placed in Melton. In the meantime, we are working around plans of getting an MRI pad in the Rutland area. We've identified a potential site. We've got activity and staff and a van identified as part of the overall LLR service. And we've got a charity who have indicated that they will support the provision of the pad available. There's a couple of practical things in terms of planning, access to toilets and etc., electricity and drainage that need to be sorted out. But we had a really good meeting on Friday at that location, and what we're trying to see is if the pad can then be multifunctional for other services to be used on there, for example, like DEXA scans which would be a very useful local service to have in place. In the meantime, the Rutland Diagnostic Hub has been piloted by Uppingham practice, which is 5 cardiorespiratory tests. They were initially part of a pilot last winter, which was very successful, and we've managed to secure funding to continue that this year, and arrangements are being made for that to be a substantive service going forward. There's been some initial really good work on prehabilitation, developing prehabilitation services for all patients on orthopaedic waiting lists with the voluntary sector and the local council. That's the aim to improve both the physical and mental health of patients waiting, recognising the waiting lists are still very long, whilst UHL and other providers are working hard on reducing those backlogs. The idea is to make and improve the fitness, mental and physical fitness of patients on that waiting list, so that when they have their procedure, that their recovery is quicker. And they're also looking at plans for implementing PIFU as patient-initiated follow-up pathways. The aim of these pathways are lots of patients go back to hospitals for follow-up appointments, and sometimes those follow-up appointments aren't really needed. It's a big issue, particularly for places like Rutland, where travel distances to the hospitals are quite long. So the initiative is that patients get the option to initiate their own follow-up should their condition deteriorate or should they have concerns, and there are indicators provided by the clinician in the outpatient appointment as to where they need to go. I think this is going to be part of a partnership arrangement, and for us to look to see how it works. Patients need the confidence of being able to ring up and have their follow-up appointment rather than go into their GP, because what we don't want to do is increase the demand on general practice when we've just gone through and talked about all the pressures there. And the final point really is that we are doing work with our outer county providers, recognising that for patients and the population of Rutland, they don't just come into Leicestershire and Rutland for their elective care. They go out. We've been doing some work with the North Place, which is Peterborough, and Stamford hospitals about what services they provide, and trying to get those links through to our primary care and make services as seamless as possible. It's early stage. There's a lot more work to do in that for elective care. I'll leave it at that, given that there's time constraints.
Thanks very much, Deb. Do we have any questions at all? Janet.
Yeah, thanks, Deb. And I think this sounds really positive for the people in Rutland. What I'm just wondering is, will the MRI pad be open every day, or all day, every day, or will the van come, say, one day a month and then go, or quite what that proposition is?
Okay, so the final details of that have not been sorted. Rutland demand would not warrant a service being open 5 days a week. There just wouldn't be enough patients from Rutland to go there. Having said that, there is a backlog of patients waiting for MRI across LR, and patients get offered a number of locations. So certainly the van could be available in Rutland 5 days a week, and staff could be there, but we would need enough patients from outside of Rutland to take up appointments to make it worthwhile. So there's some work that UHL need to do as part of siting a van in Rutland, to ensure that it gets full utilisation. It makes sense not to move them about too often, because obviously it takes resources, and although they are designed to be mobile, the more you move them, the more potential there are for issues. So the practicalities of that will be sorted when they look at where the patients live that are on the waiting list and how far they will travel. We have found that people are willing to travel for MRI scans generally, but they do like a choice of when's available.
Thanks, Deb. Any other questions at all? I've just got one, Deb, that I'll put to you. You might not be able to answer straight away, and it's a question that came up with regards to the enhanced care and RMH. And I know Mark's going to come in a moment regarding Rutland Memorial, but this stems from a service commissioned by the ICB through RMH, and that's the out of hours. Because of the enhanced care, there's confusion around our out of hours. So currently we have out of hours by OMP up until, and I'm going to get this wrong, it's either 5:30 or 6 or 6:30, one of those three. And then after that we have, sorry, that's minor injury. And then we have minor illness clinics run by DHU, Monday to Friday in the evenings till 9, and then Saturday and Sundays. Is that service being maintained with the separate to the enhanced access from GPs? Could we have some clarity? I appreciate I'm dropping it on you now, and you may not have the answer, but can you come back so we can back? Because I think it's really important that we clear that up and make sure that we've got that correct in our heads.
I can give you a brief comment on it now, but I would need to get some further details. So certainly that service and services like it around LLR will be in place until the end of March at least. I think that there is likely to be a consultation process with the public to see about the utilisation of those services in some of the spokes, because they're not well utilised in all areas, and they are minor illness services, for which some of which the enhanced access appointments are another offer. So that's as far as I know for now. We can get some further details of the likely consultation and how that will work forward. I know Janet's been involved in some meetings, so she might want to come in.
Sorry, apologies, Chair. We have reached time.
Okay. What do I have to call? Do call an extra 5 minutes or 10 minutes?
We are allowed 2 15-minute extensions, which would take us up to 5 o'clock.
If we can take a vote, if we can have our first extension for 15 minutes, if I propose, if we can have a seconder, please. Thanks, Deb, and all those in favour. Janet, what we haven't got time to go whole. I'm really conscious that we've got other bits to come forward. So what I would suggest is if we can hold it in the minutes, and we'll ensure if there is consultation.
It's very quick, Sam. It was just to remind Deb that we were supposed to be getting some data on the footfall at RMH, as particularly at the weekends, Saturday, Sunday, and we've not seen it yet.
Okay, so if we can bring that forward outside the meeting, that would be great. So on to Mark Powell, just regarding Rutland Memorial. I'm really sorry, just to bear in mind, I'm going to only give you 10 minutes on this, so if you can do a whistle-top tour of your slides, we will take it that people have read them. I think we'll go with that and talk at the slides, and that would be great. Thank you so much, Mark.
Yeah, thank you, Chair. So for those that don't know me, my name is Mark Powell. I'm the Managing Director and Deputy Chief Exec for Leicestershire Partnership Trust. So nice to meet those of you that I haven't met before. I will keep it brief, and obviously you've got the paper in front of you. I'll pull a couple of points out in a second. But first, I just wanted to apologise actually for how these particular upgrades and refurbishments were communicated to partners. We had a few issues around that communication probably 5-6 weeks ago. So just wanted to put on the record that we're sorry about how that panned out with stakeholders as well. In terms of the actual paper itself, just 2 or 3 quick points, then happy to take some questions. You'll see from the paper that this is about significant upgrades and refurbishment to Rutland Memorial Hospital, which obviously is positive news. There's quite a significant programme of work that is taking place. That has resulted in some temporary changes that we've needed to make to the inpatient ward and working with other partners in the hospital as well. But pleased to say that that's all working its way through at the moment, and regular dialogue and communication with partners as well. We have obviously temporarily closed the ward, but that will reopen again once all the work has taken place. We're still on plan to get all the work completed by the end of January, and there's regular sort of communication going out to key stakeholders as well. So as I say, I just wanted to apologise about how it came about, but the work planned is progressing well, and as I say, hopefully we'll be in a position to get everything back reopened by the end of January, Chair.
Thanks so much, Mark. Do we have any questions? No. That was very brief then. Thank you very much, Mark, and it's lovely welcoming you to the board, because I believe you'll be coming to visit us more often, so that will be ideal. It would be great if you could keep us updated, so if there is any pushback, or if it does take longer, then it would be great if you could let us know so we can.
No problem, happy to do that. Yeah, no problem at all.
Thank you so much. So that's great. We will swiftly move on to, I think this is over to you, James, I think, again, for our winter vaccination programme. I'm going to limit you to 5 minutes. So if we can take the slides as read again, they start at page number 259 in our pack, and we'll whip through them really quickly, if that's okay, and give us the broad headlines for. Thank you. We can see your slides, but we can't hear you.
I've unmuted myself now. I thought I'd got away with the whole meeting without messing up. I do apologise from that point of view. Can everybody see the slides? Yeah?
Yes.
Lovely. That is Rutland. Sorry, it's coming through slower than I thought it would. Effectively, there are 2 providers providing vaccinations, Rutland PCN and Rutland Late Night Pharmacy. And in essence, we will be covered. Rutland PCN obviously has the 4 practices: Market Overton, Somerby, Oakham, Empingham, and Uppingham. Fundamentally, when you look at the numbers of patients who live in Rutland and have a Rutland GP, largely there's a fairly high correlation from that point of view, but some patients will have GPs outside of the area. All 3 partnerships or 4 practices have opted to deliver COVID vaccinations. In fact, there's one going on outside of my door at the moment. And surgeries will be delivering this in evening clinics, Saturday clinics, and then some clinics during the day. Practices receive their deliveries of vaccines the same way as they did originally. We haven't been given 20,000 vaccinations at the start of the programme, and there you are, get on with it. We get an amount per week delivered from that point of view. The important bit this year is you could deliver the flu vaccine at the same time as the COVID vaccine, which helps make it a bit more efficient from that point of view. All of the housebound patients and care home patients have been vaccinated by the PCN staff, and then the clinics are being put on largely in risk order, and will be continually rolled out through October and November, December. There's no need to stay in the building for 15 minutes after the vaccination unless you've had an anaphylactic reaction or other health risks from before. So fundamentally, the practices patients who might be receiving vaccines from other areas will be places like the Well in Stamford, Stamford Day Centre, Stamford Superdrug, or their practices in Stamford and Corby from Lakeside. They're also delivering some vaccinations, but realistically, patients living in Rutland registered with an out-of-area GP practice, they've got an option. Their options for vaccination is to book an appointment with their registered practice or book an appointment through their national vaccination website. For problems for out-of-area patients being vaccinated by Rutland practices, effectively you'd have to temporarily register at the practice, and having the vaccine at the surgery makes it slightly more inefficient and difficult to transfer the information. So in general, it's best for patients to have their vaccinations at the surgery that they're registered with, or other local providers, which are still using the national Pinnacle system, which correlates effectively exactly who's had the vaccine. And that it's a very brief presentation. Hopefully, I might have saved a tiny bit of time. But effectively, the program is up and running, and with vaccines being delivered. The highest risk population groups, housebound and care home, have all been vaccinated and were vaccinated first, and the rest of the clinics are being rolled out in a sequential manner.
Thanks very much, James. Can you just confirm that the just like before when we were the vaccination centre was at Catmus, that you cannot book to your vaccination to your GP through the national booking system? You need to wait for your GP to contact you. So that's important for members of our public. If they're contacted from NHS either by text or email, then if they want it done at their GPs, they need to wait for their GPs to book them, because if they follow those links, they will not find their GP practices on there.
Yeah, and they've had a choice, so they can go to a national vaccination centre, or effectively one of the places that are delivering it, say some of the pharmacy groups. So they don't have to wait for the GP practices. The GP practices will be contacting patients and have a rollout. Obviously, you don't send out 15,000 texts when there's only a certain number of appointments on, and that links to the vaccination, the number of deliveries, etc., that we can plan for. So absolutely, people can have the two portals of how you book an appointment.
Thanks very much, James. Mike.
Yeah, thanks, Chair. Thanks, James. It's really useful. I know my counterparts in Nottingham City and Nottinghamshire did a joint twindemic fears, which the Nottingham Post picked up and ran as their front page. I don't know if I'm quite in that space of wanting to sort of scare the fear, put the fear of God into people about they need to get their vaccination, because I think it's a little bit too early. Nonetheless, I guess I know your comms colleagues across the ICS will be doing a level of comms. Just thinking it'd be really nice to do a joint health and wellbeing board, Rutland Health and Wellbeing Board comms thing, which picked up on the good relations thing we developed over COVID, for me in particular, with the radio stations, both commercial and then the community radio station within Rutland and the local press. So I just wonder if there's an appetite for a group of us to get in touch, I think more with comms in the council and channel it through there as Chair, me and you, whoever else wants to be involved, asking for people to get jabbed, get the both at the same time.
Absolutely.
I was going to say, James and I had actually had a conversation about some joint comms in order to kind of give the public clear kind of knowledge of how. So that would be fantastic if we can add that as an action for Mike, myself and James to do that. That will be fantastic, and picking up through Mike, through our previous comms connections we had. That would be great. Thank you. Is there any more questions on the winter vaccinations? And if not, we will move on to the essential cost of living crisis that's coming up. Welcome, Emma Jane, to the meeting. Thank you so much for waiting in the wings so long for us. And over to you, and I think Duncan as well from CAR are also going to help. So who'd like to go first? I'm really sorry that we do only have 10 minutes, so I'm going to have to rush you for 5 minutes.
Chair,
Oh.
you voted for 15 minutes. We're just about to run out. So if you want to vote for another 15 minutes, that will take us up to 5 o'clock, and it'll stop us interrupting Emma and Duncan then.
Thank you so much. Yep, Debs and everyone's approving, so we're good to go. Thank you very much. If I can give you 5 minutes each, I know that Jane will close us down at 5 o'clock because we have a complete cut-off at 5. So if we could, and apologies that we're going to rush you through this such important work. Please okay. Carry on.
That's okay. Hopefully you can see the slide that I've just put up. Hopefully, has that shared with you?
It has shared. We can't see it full screen.
Right.
We can see your computer as well, but that's it. Perfect. Thank you so much.
Okay, so I'll just whiz through this. There is obviously 2 levels of work going off in this area, one across LLR and one more locally for Rutland. The slide I've put up is just purely focused on Rutland and what we're doing locally. So my urge for you all is to note down the website address, which is our own Rutland County Council website with a page that's / living costs on it. We are, and the reason I've put the slide up, in the process of producing a lovely little leaflet. That's the picture of its front cover, so watch out for it. And in there will be a range of information for people to actually, if they're not able to access digitally our website, have a flavour of what support is available for them. Basically, it's focusing around making sure that there are places in the county that people can go and access free Wi-Fi and also keep warm while they're there. The libraries being one of them. We are being approached by churches as well, who are opening their doors for people to go and keep warm, hopefully get a cup of coffee so that they're not at home freezing. We are signposting through the RISE team and our prevention services of adult social care and children's social care to preventative services using various places such as the carers support, Longhurst and the housing MOT, and linking into the voluntary sector. There is a really good government website called Help for Households that is on the webpage of Living Costs, and I urge people to obviously point themselves in that direction. The reason being is because the government is putting out lots and lots of information and keeps changing the amount of money that they're going to be offering people. So to get the latest on what you can get help with, whether it's council tax or whether it's grants or whatever that might be, that household government portal is really useful. We are working very closely with the food bank and the community fridges that are open in Rutland. And we are also working really closely with citizens advice colleagues. And I want to hand over to Duncan now, because I know that Duncan is working really hard with the crisis fund and also has put in some bids to expand that, which we're hoping that we're going to be able to support him with. So I'll hand over to Duncan if that's okay, and Sam, and I'll try and stop sharing as well.
Thank you very much, Emma Jane. Duncan.
Thank you, Emma Jane. I think probably the easiest way to dive into this is to whisk you through the statistics in Rutland for September, the most recent, to give you an idea of the picture. Demand for our service in September is up 40% on what it was this time last year, and last year was kind of in and out of pandemic, so the demand was higher. If you break that demand down, 60% of people coming to see us are coming to see us around benefit, 10% around housing, 5% around debt, and 25% around other issues. The number of referrals we're making to the food bank is up, and I know that the food bank are dealing with 30% more cases this year than they were this time last year. Both CAR and the food bank are seeing an increasing number of people coming to see us who are first time coming to CAR, first time coming to the food bank, and an increasing number of them are in work currently. So we are seeing the demographic changing as the cost of living crisis starts to bite. What is surprising for us in the September figures is that we haven't seen an increase in debt. If anything, we've seen the debt numbers go down, and we haven't seen an increase in fuel poverty. And we put that down to the fact that people haven't turned their central heating on, and they've had the first of these government support payments. So that's alleviated the bills, and the second payment is coming on the 8th of November. So we haven't seen that uptick, but we are expecting to see it as the winter gets worse and as things get colder. If you drill into the figures, the benefit in Rutland, welfare and benefits is the biggest sector of clients that both us and the food bank deal with. And I think it might be useful for this group to understand the banding of that. So universal credit is the vast majority of the cases we deal with. If you're a single person on universal credit under 25, you get £265.31 a month. If you're a single person over 35, you get £334.91 a month. If you're a couple under 25, you get 416. And if you're a couple over 25, you get 525. So within universal credit, there is a banding. And if you're at the bottom of the banding, you're going to be worse off than if you're at the top. And if you live on your own, you're going to be worse off. The same thing goes for the state pension. A single person on state pension is getting £791, whereas a couple is getting £1,207. So again, if you're at the bottom of the banding on the state pension, you're going to be worse off. On top of that, people are entitled to claim housing benefit, but if you live with a private landlord, you may be expected to top up your rent. And on top of that, you will have to make a 25% contribution to your council tax. So that the point of all of that data is to illustrate that even within certain benefits, that there are certain people who are already on the extremes of poverty. If you add up the gas, the electricity, the contribution to council tax, the increase in energy bills, the increase in food bills, to somebody on £265, which is a single person on universal credit, you're already in negative equity. When we do an income expenditure analysis, that we're finding those people are already headed for debt and arrears on their bills. And we are expecting that situation to get worse. The government's energy price guarantee is a positive step in that direction, but that is based on an average bill of £2,500 on a well-insulated house with modern efficient appliances. And many of the housing stock in Rutland, the bill will be above £2,500 a month. On top of that, if you add to that, the food inflation is now at 10.4%, which means that the average household food bill has gone up by about £500 to £600 a month, and that continues to rise. So those people in the county at the bottom end of the scale, be that universal credit or pension, are probably already in debt at the beginning of the month when they receive their payments. And we are expecting that situation to get worse as things go on. I'm going to share with you in the chat a resource, which is the Citizens Advice National Dashboard for cost of living crisis. It has national data as well as Rutland specific data, worth having a look. It's updated quarterly by Citizens Advice, and it has data from Citizens Advice nationally, as well as the Department of Work and Pensions, and you will find that Rutland is essentially a microcosm of the rest of the country. In terms of benefits, the only area I would suggest that we differ is that our ethnicity is less diverse than other places, and I think that in Rutland we have more areas of rural isolation, and we have more people in the county who are living in the affordable housing in the villages who are not accessing the services of Citizens Advice or RCC or the food bank, and how we access and identify that group of people is an issue that we constantly struggle with, and we're constantly trying to get our head around.
Thanks. Sorry, Duncan. I was going to say, can you share that with Jane, because the chat will vanish.
I will email that to Jane after.
Then she can send it around. I'm really sorry. I'm just very conscious. We have literally got 7 minutes left. We've got a couple of hands up. If I can come to them, and then we'll come back to you if that's okay.
That's perfect.
Duncan. Thank you. So Janet was first, and then Mike. If I can ask you to be really succinct, that would be fantastic.
Yeah, it's just to let everybody know that Health Watch Rutland is having a meeting on the 3rd of November at Voluntary Action Rutland in the Gover Centre from 2 o'clock till 3:45. And the main theme of the day will be talking to health inequalities. Well, the actual thing is, how can health inequalities in Rutland be addressed in the face of the escalating cost of living? We're hoping to get quite an audience with a panel from Health and Public Health and Rutland County Council to be able to answer questions, etc. So everybody is welcome to address what is really a very important issue.
Thanks very much, Janet. Mike, over to you.
Yeah, thanks. And thanks, Emma Jane, and thanks, Duncan. It's really useful. In addition to all the other data, and I was particularly struck by that kind of, the biggest queries coming through is benefits, etc. From a health and health inequalities point of view, have you got data on the sort of percentage of calls coming in that also breaks those categories down by sort of age group and health inequalities groups? So I'm particularly thinking, you've mentioned rurality, all the other things that are driving things that would be different in Rutland, but I'm thinking, how many queries have we got coming in that are from a health point of view, that sector that'd be most at risk? So older people living in cold housing who've turned the heating down, it's poorly insulated, and they've got long-term condition. It's almost the overlay of housing condition, deprivation, age group, long-term condition, all of which makes people more susceptible to being at the sharp end of really suffering from this quicker.
There is some of that data on the data sheet that I will share, which is national. The problem we have in Rutland is that we collect our data using the Citizens Advice case note system, and it doesn't always ask people's ages, but we can make assumptions that if you're on pension or pension credit, we can figure out where you are. So we don't explicitly ask that, and we have issues around confidentiality, but there are ways that you can divine it.
That'd be useful, because again, even age group in itself wouldn't quite nail it, because you could have people with a query.
I'll put you in touch with my COO.
Fantastic, thank you.
I think I know I'm conscious that we're running out of time. I think what I will say is that we're in a very kind of interesting time at the moment. Excuse me 1 second. In that there are lots of variables we still don't know about. Mortgage rates are now going up, so there will be another potential housing issue there. We don't know what the government is going to do in terms of aligning benefits to inflation. We don't know where food inflation is going to go. So there are a lot of variables, and we're watching these at the moment, and not us, but the entire Citizens Advice network is trying to figure out where we're going, and also the severity of the winter. If we have an Indian summer, we'll be grand. If we have a beast from the east, that's also going to put more pressure and more strain on the system. So we will continue to inform this group and anybody who'll listen. And in the next 2 or 3 months, I think a lot of things are going to become clearer, and then we will know how big, what the increase in the demographic of the people we're trying to serve is. We know it's going to get bigger. The question is by what scale? And the last thing I'll add is that the levers available to us are also less and less in terms of dealing with fuel poverty. We used to tell people to change tariffs. That can't happen anymore. And in terms of food poverty, with food prices going up, food banks across the country are seeing donations to them fall as well. So we're in a period where everybody's watching it. We know the situation is likely to deteriorate. The question is by how much, and we'll keep feeding back into this group and letting people know.
Thanks so much, Duncan. We've got 3 minutes left before Jane will pull the plug on us, so I'm going to be really succinct. Emma Jane, can I just confirm, when do we think the leaflet, is it going out to all households? It would be my first question. And when do we think the leaflet will be ready to give information? And when will the link on the website be live?
Yeah, the leaflet isn't ready at the moment. I'm hoping I will chase our comms are leading on that. So I will chase them and get a date for you for when that's available. I'm not aware that it's going to go out to every single household, because obviously printing costs and everything would be huge. But we will make sure that it is readily available for those that aren't able to access the information online.
Thank you very much. Do we have any other questions from anyone else? I appreciate we've given that less time than I'd have hoped, but I appreciate we're really constrained now. If not, we were due to review the forward plan and annual work plan. If anyone's got any comments, please pass them back to us. Any other urgent business? I haven't got any, Jane, and I'm hoping you don't, because we've got 2 minutes. No, the date of our next, sorry, I should have said, we've distributed 2 items which are purely for information. If you've got any queries on those massive documents, please do come back to us. The next planned meeting is now an in-person meeting on Tuesday, the 13th of December. Thank you, at 2 o'clock at the council offices. I would ask if you, as I said previously, if you can prioritise it, it will be on the joint health and wellbeing strategy, which is the system partnership strategy. I think that's it for this evening now. Thank you so much, everyone. It's been a massive meeting. I'm amazed we got through the agenda, but thank you all for your time. I really appreciate it. Thank you.
Thank you, everyone.
Thanks all. Bye-bye.
Thanks, Chair. Thanks all.
Bye.